Hello everyone. So this is going to be the second part of the pediatrics study with me active learning session, and it would be similar to the previous one, and the difference would be I've changed the mic, and if you can if you go through the previous one, you might have noticed that the buzzing sound in the background which has disappeared. And yeah, so right now it is we are at protein energy malnutrition, so we would be covering this entirely, and we'll see how far we can reach. And yeah, so let's begin. All right. Yeah, so etiology of PM, protein energy malnutrition. So PM, as you can recall, it is entirely the definition. It encompasses both proteins, it contains even the calories, vitamins, and also other essential nutrients which is required for normal body functioning, and which comes from proper organ maintenance. So what causes it? Inadequate dietary intake, medical causes. So first is intake is less, other one is medical causes, so some pathology in the body, prenatal and neonatal. So since this is pediatrics what we are specifically looking at, we are also thinking about perinatal, neonatal, and social and environmental factors. So first one, inadequate dietary intake. What is it? So you can talk about social factors, socioeconomic status, poverty, and some kind of the behavioral patterns. Medical causes like various illnesses and diarrhea, pneumonia, recurrent infections, chronic malabsorption. This is from the childhood. Child can have celiac disease, cystic fibrosis, and parasitic infections can cause anemia and other illnesses, and TB, asthma, congenital heart diseases. All of that can can cause more of the nutritional disorders, because it's a chronic inflammatory condition. This one is chronic inflammatory. So what happens is the nutrients which are normally taken, they get diverted into this pathology. So it goes on, the nutrients, they try to solve this pathology rather than being used for the organ development and normal body functioning. And same is the case with asthma. I think it's more related to one is immunological section, other one is you don't have enough oxygen. Is that considered? Not particularly, but more of inflammation. I think in this case it's chronic hypoxia. Perinatal and neonatal, low birth weight due to maternal malnutrition. This one makes sense. And this one is I think this is more of it exacerbates the existing condition. And preterm delivery, same thing. Preterm meaning the low birth weight, and there are poor nutrient reserves. And then social and environmental factors like large family size, poor birth spacing. So this comes back to the same thing, the social, working mothers, and same social factors, poor sanitation, open defecation, and unsafe for drinking water. Next, coming to the pathophysiology, inadequate protein intake. So there are multiple. So first one is for specifically for protein deficiency. There is less of, if you are taking less of proteins, less of specialized proteins which are serum protein, those are being less formed, and this reduces the oncotic pressure, and edema is the main feature when in case of protein deficiency. Low energy intake, depletion of glycogen stores, utilization of fat and muscles. So rather than using glucose, you are using other things, and that causes marasmus, which is wasting. So can you recall what the wasting is all about, where your height is normal but your weight reduces, so weight for height is less. And then reduced amino acid availability and immune functions, immune functions are reduced. It's called deficiency of enzymatic activity leading to poor digestion and absorption. Endocrine and metabolic disturbances. So increased cortisol and catecholamines lead to increased protein breakdown. So other conditions exacerbate the endocrine and metabolic factors. Insulin-like growth factor is reduced, leading to stunted growth, and impaired lipid metabolism, leading to fatty liver in kwashiorkor. Classification of PM. So expected weight for age. So first one is Wellcome Trust classification based on weight for age and edema. Next one is IAP classification of malnutrition under 5 age group. Next one is WHO classification. So first one, Wellcome classification, 60 to 80%. One is 60 to 80%, next one is less than 60%, and you have edema present or absent. So whenever edema is present, the word kwashiorkor is added because it's protein related, but whenever it is absent, there is no kwashiorkor. So it can be either you can either put it as undernutrition or marasmus, depending upon the weight for age in terms of percent. So if the weight for age is little bit more, meaning 60 to 80%, you put it under undernutrition. It's like a fine term, but if it is less than 60, it is marasmus, which is like a really big pathology, which we are going to study about in later sections. Coming to IAP classification. So this is also based on weight for age, but here edema status is not included, and here it is greater than 80%, 70 to 80. So 50, 60, 70, 80 and greater than 80. Greater than 80 is normal, and less than 80 weight for age. There are different grades, so remembering the numbers, and grade 1, grade 2, grade 3, grade 4 should be, I think, doable. Grade 4 is less than 50. So remembering the first one, remembering the last one for IAP, and the first one being normal, last one being grade 4. The 4 grades. First one is normal, last one is grade 4 and less than 50%. So it should help. Next, WHO. I won't call it WHO. It is WHO. First one being, so what we look at, weight for age, height for age, weight for height, and interpretation. So if everything is normal, it is normal. Then we have 3 more conditions: acute malnutrition, chronic malnutrition, acute and chronic, acute on chronic. So acute, weight is less, weight for height is less, but height is normal. So you are a normal person, you are eating less, lot less, then what happens? Your weight reduces. Based on your age, your weight is less now, and based on your height, what normal weight you require, it is less. So BMI is also reduced in this case. Acute malnutrition. Chronic malnutrition, weight for age is less, okay fine, height for age is less, but weight for height is normal. So how do we go about thinking about this? So height for age. So height for age meaning it is chronic, so over a long period of time. So short periods of time your height is not affected if you are for a child, but for a really good period of time the height is affected, which is a little bit of problem. And then there is weight for height. And this leads to chronic malnutrition. So weight for height, meaning height is reduced, weight is also reduced. So weight for height remains normal, and that is chronic malnutrition. And everything is decreased, it's acute and chronic. And now there is different. There are different ways, different. So marasmus, kwashiorkor, main classifications of PM. So marasmus, that is the first one we are looking at. Then kwashiorkor, then comparing both. So let's compare both, then go to each of them. That would be very nice. So first one, cause. One is energy deficiency and protein deficiency. So protein deficiency means edema. So edema present. Muscle wasting, it is mild. So muscle wasting is seen in both, but mild in case of kwashiorkor, but severe in case of marasmus. Subcutaneous fat present in kwashiorkor, absent in marasmus. Appetite is good, meaning I remember a professor telling about if you give a biryani to the marasmus child with marasmus versus a kwashiorkor, the child with marasmus will eat the biryani very fast. It is very hungry, but not the case with kwashiorkor. Just coming to mental status. So alert, irritable in case of marasmus, apathy and irritability. So you can remember, you give food to the kwashiorkor child, it's not eating properly and it's lot of apathy and irritable. Skin changes are absent in marasmus. Flaky pain dermatosis. I think this one is a keyword, should be written in clinical classification. And also the word flag sign, this term, a flag sign should be included. But in case of marasmus, the skin changes are absent and sparse and thin hair changes. Now coming back to this, so marasmus derived from the Greek marasmos, meaning wasting. So wasting, a severe protein wasting seen due to chronic energy deficiency. So energy is a keyword where calories are deficient, common less than 5 years. Severe wasting, loss of subcutaneous fat, so muscle and fat reduction, wrinkled skin, so old man appearance. This is important. Old man appearance, sunken eyes, prominent ribs. So let's see an image. Marasmic child. So this is say prominent ribs and all that. So alert, irritable or apathetic. Yeah, this one is frequent. So irritable, so it can vary probably, but in the classification, since we are more of it is more of alert and irritable, maybe that is the differentiating factor compared to kwashiorkor. Frequent infections, diarrhea. So this is obvious because we have less of immune function. Bradycardia, hypothermia, hypotension, volume status is less. I think that is the case. Yes. Polyphagia, voracious appetite. Yeah. Clinical features: loose skin folds in axilla and groin, loose skin folds in buttocks and thighs, wasting of chest and abdomen, buccal pad of fat. So last one I think doable because you can remember the which one is it? Alcoholic. This one, chronic alcohol consumption, where you have less of the parotid prominence is high. So last one is fine. First three, loose skin folds in axilla and groin, then buttocks and thighs, and chest and abdomen. So A, B, C: axilla, buttocks, chest. The last one is what is it? The buccal pad of fat that it reduces. Next, coming to kwashiorkor, which is edematous malnutrition. As edema is present, protein deficiency with adequate calorie intake, common in children 1 to 3 years, after abrupt weaning. So 1 to 3 years. Kwashiorkor means disease of displaced child. Why is it called that? Weaned off breast milk, switched to diet high in carbs but less in proteins. Okay, displacement in terms of diet. That is how we can go about thinking. Clinical features: generalized pitting edema due to hypoalbuminemia. Muscle wasting is seen, but it is minimal. But there is retention of subcutaneous fat, which differentiates it from marasmus. Mental changes: apathy, irritability, apathetic. What does apathy mean? Like sadness or some sort? Disinterested feeling. Yeah, sadness meaning it's a term even used in the one of the criteria in depression. Okay, coming back, moon phase is the keyword, which was a old man appearance. Old man, here it is, moon phase. Hepatomegaly, so fatty liver. Flaky pain dermatosis, crazy payment dermatosis. Let's see how those look like. Images. I'll return this. Run search. How do you see this? Okay, fine. Sure. Maybe this is the one. Yeah. Okay, I can't remember this. I don't know why there is no option to change this one to get. Maybe then now I'm recording this. Yes, spastin with depigmented air. Spastin is common, but flaxine is more of kwashiorkor this one. And management. So management is given in extreme detail in the textbooks, but I can't remember all of that. So this one is a shorter version. It's basically when you are actually doing it, you can expand more on this, whatever the management here is present. So stabilization phase, rehabilitation phase. Stabilization, first 7 days, then week 2 to week 6 is rehabilitation. So second phase is much longer than the first one. So first one is treat hypothermia, warm clothing, kangaroo mother care. Treat hypoglycemia with 50 ml of 10% dextrose orally or with NG tube. 50 ml of 10% dextrose. 50 ml of 10% dextrose. Treat dehydration. So hypothermia, hypoglycemia, dehydration. Hypovolemia, hypovolemia, yes. Hypoglycemia, hypothermia, hypovolemia, reduced osmolarity, resomal. Treat electrolyte imbalances. Just potassium comes first, magnesium comes second, and zinc comes third. Treat infections, that is with empiric antibiotics. Ampicillin, gentamicin. F75 diet, 75 kilocalories per day, that is per kg per day, given every 2 hours. So these are the few points, 1, 2, 3, 4, 5, 6 points. There are more, there are a lot more in the textbooks, but these are bare minimum which I can remember easily. And maybe in the exams, when you have so much of content to get inside your heads, I think something short would be nice. Yeah, coming to rehabilitation base. So F75 changes to F100. I think it is F1. Yes, here it is. 100 kilocalorie, gradual transition. Increase in calories to 150 to 200 kilocalories. So increase in protein to 4 to 6 grams per kg per day. Gradual transition, that one is add complementary foods, encourage physical activity. Last, coming to follow-up care, discharge criteria. So after rehabilitation, no, not rehabilitation, probably during rehabilitation somewhere, like after you stabilize the patient, maybe even during that point of time, or else during stabilization, you can discharge the child. And what is the criteria? Weight of the child greater than 90%. So what was the cutoff? Less than 80%, which made it under one of the grades, which got it in one of the grades. Edema resolved. So edema, the child shouldn't be kwashiorkoric. How do you? Child shouldn't have kwashiorkoric features. Consistent weight gain greater than 5 grams per kg per day. Immunization, so weight gain more than 5 grams per kg per day. Yeah, so 5, 4, 5, 6. Increase in protein 4, 5, 6. So increase protein 4. Weight gain is 5 grams per kg per day. Extra is 6. Immunization, caretaker education. prevent relapses with adequate nutrition, hygiene, supplementation. Yes. So we're done with PEM. This is a 10 marker. Weaning. So weaning specifically in Arun Babu, it is given like complementary feeding, but both are slightly different. Like weaning, it is a gradual transition of, in this particular case they have given it as, it's a gradual introduction of solid and semi-solid in addition to breast milk to meet the additional growth requirements, additional nutritional requirements of an infant. It is critical for in child development, ensuring proper growth, brain development and immunity. So four things: child development leading to ensuring proper growth, brain development and immunity. Importance of weaning: prevents malnutrition and infections, promotes growth and brain development. So malnutrition and deficiencies, growth and brain development. So we have seen it here itself. Immunity, again here itself, has been run exclusive, comes in the definition. So expanding on definition gives the importance. Optimal weaning practices: first 1000 days of life, that is first 270 days of intrauterine life, that is 270 days of intrauterine life plus 2 years are essential for growth and development. This comes to about how many? About 2 almost 3 years, 2 years of life. First 2 years of life are crucial. Recommended age of weaning: begins at 6 months of age when breast milk alone is not sufficient. Continued breastfeeding is advised at least 2 years. What WHO and UNICEF guidelines say: early initiation of breastfeeding within first hour of birth. Exclusive breastfeeding for first 6 months. Appropriate complementary beginning from 6 months, but you don't stop breastfeeding. You just like more of other. You start adding other things. There are some principles. First one is begin at 6 months of age. Okay, we have seen that earlier. Introduce one food at a time to identify allergies. It's like a scientific process. Prefer home cooked rather than processed. Encourage self feeding as the child grows. So habits to make sure that the child gets into the habit. Increase food variety and consistency gradually. Variety, balanced diet. Energy dense foods should be preferred over bulkier foods. So rather than the bulk, you look at, what does this mean? Bulk. Meaning and meaning. Should include more calories and nutrients rather than large volume of large calories. So examples: mashed banana, avocado, nut paste, egg yolk, watery porridge, plain rice, starchy foods. Yeah, you get the point. Simply eating is not enough. It should have something. Avoid excessive cow's milk greater than 500 ml. So this is the first number we got. Second number actually in this principle. So one is 6 months, one greater than 500 ml. To prevent iron deficiency anemia. Is that maybe something related to calcium and chelation in the GIT? I'm not sure. Anyways, breast milk should continue 12 to 24 months. So up to 2 years, as we have seen earlier. Avoid allergic foods such as, so once you identify what the allergic things are using this scientific process, avoid some things which are allergic: cow's milk, soya beans, fish nuts. No, meaning you avoid it completely in the early weaning, and slowly you start including it. Because the child is small, maybe when the child is small, you don't want to stress out of for nothing. Types of weaning: so thick porridge, so divided into 6 months, 3 months of difference, 6 months, 9 months, 12 months. So when you start, it is 6 months, then it increases to when you start till 6 months it's pure breastfeeding, then includes weaning. And kilocalories, so it increases by how many? 200, then increases 300, then plus how much? Here it is 100 difference, here it is, if it was 100 it would have been 400, it's 250 difference. Why? Because it is almost next 1 year is also covered, so 1 to 2 years, this is 1 to 2 years, so it is 550. Thick porridge, mashed foods, mashed potatoes, thick porridge, mashed foods is 2 to 3 meals. Wait a second. Yes, 2 to 3 meals. 2, 3, 4. 2, 3, 4. Yeah, that's a frequency. So thick porridge, mashed foods, finely chopped mashed foods. So the second one, that's family foods. So by the time it is 2 years, it needs to be eating family foods along with the previous things if it is required. But frequency is 3 to 4 meals, which is breakfast, lunch, dinner, and snacks. So it becomes adult like frequency. Recommended foods: iron rich. What are those? Meat, eggs, iron fortified cereals. Protein rich: legumes, dairy, eggs and fish. So iron, protein, zinc. What is zinc? Where do you find zinc? Dairy, wheat, milk, meat. Vitamin rich: fruits and vegetables. Energy dense: oils, nuts and dairy. Indicators of successful weaning: steady weight gain on growth charts. Okay, so we looked at what? Looked at definition, importance coming from the definition, optimal. This is some criteria designed by WHO, UNICEF and some recommended committees, and then we have certain principles. These are like laws, better to follow, meaning not laws, principles, meaning some kind of management, some kind of techniques which you can follow, coming from the guidelines, expanded upon the guidelines. These are the types, like what can you give. Next one is indicators. So what is the outcomes? What are the outcomes that you could visualize? Steady weight gain is one. Second one is child accept different textures and flavors, so it learns. Next one, no signs of malnutrition deficiency, so this is coming to the first one. Steady weight gain, no signs of malnutrition. Normal bowel habits and digestion, so the gut is ready to eat properly. Early weaning, less than 6. So challenges: early weaning, delayed weaning, poor weaning practices. So this is a qualitative problem. This one is based on the timeline. First one, risk of infections due to contaminated food. So we saw quite a few cases in the, at least in PSM, where child gets contaminated food and you ask what the, not in this one, it was in microbiology, and what is this thing, E. coli and all of that. Cases of diarrhea in the diarrhea section, also in the GI tract. Where is it? Somewhere down. We'll see infectious diseases here itself. We'll see this repeated. Malnutrition due to inadequate nutrients. Inadequate nutrients meaning bulkier foods. You prefer that over energy dense. Allergies due to immature growth, immature gut immunity. Next, coming to delayed weaning, greater than 6 months. So early weaning meaning breastfeeding, same time you are giving extra food, so that is not okay. So couldn't actually process it. So early weaning meaning before 6 months. That's the time when breastfeeding is happening. Greater than delayed weaning meaning that time you need to include, but something is some issues come up, which include nutritional deficiencies, growth retardation, delayed chewing and swallowing skills. These are the challenges and complications. Now, poor weaning practices: feeding thin gruels with low energy. This is the same thing. Inadequate hygiene causing infections. Bottle feeding, spoon feeding, poor oral development. Bottle feeding, oral feeding. And second one, then last one, age independent anthropometry. So what is age independent? Meaning it's not height, weight and all that. It's something else. Some circumferences, BMI, Kanawati index, Rowskin index. That's very short section. Definition: age independent anthropometrics. Indices are objective measurements used to classify malnutrition and nutritional status independent of child's age. So what do you used to classify measure. So same thing like the previous one, malnutrition and nutritional status, but are independent of child's age, and these are objective measurements because some kind of objective criteria has been designed. These indices remain constant within specific age groups, making them useful for assessing growth deviations. So it's self-explanatory. Types of age-independent anthropometric indices. So first one is mid-upper arm, not mid-arm, mid-upper arm circumference, used between 6 months to 5 years, measured midpoint between tip of the acromion process, which is here, the allochronon somewhere over here, midpoint. Yeah, here to acromion to this, yes, somewhere over here. Left arm is when relaxed. So Shakir's tape, Bangle test, non-stretchable measuring tape. Any of these could be used. Most commonly, what we hear is the Shakir's tape. What are the numbers? Certain, I think we have seen this earlier. No need to repeat this. 12 point less than 11.5 is severe malnutrition. Coming to BMI, weight for height. BMI formula: BMI weight kg by. There's a weight. I need to cancel this. I need to write it properly. Yeah, weight by height square in meters. So weight by height square in meters. I think yeah, I change this later. So I'll just make note of things which I need to change. A new document. I'll just take a screenshot of this whenever I find some kind of issues, and I'll make sure to change these later on. So this is another benefit of doing this active learning sessions, where I can find certain mistakes, like personally, which me as a creator, I should know what mistakes I committed so that I can change those. Yeah, coming to interpretation: underweight, BMI less than 5th centile, overweight greater than 85th centile. So centiles, again, remember it's a Gaussian curve. So Gaussian curve, there is 50th centile, which is most of the people lie in the 50th centile, and on the right end you have obesity. In this case, for example, BMI. On the left end there is undernutrition, underweight, overweight, obesity. So the numbers are also there. I don't know where those numbers. And weight for height. I'm not sure if it is applicable to children. In adults it is, yeah, it is used, the BMI, but in adults, in children, no, it's not here. Probably it's not there. It's only for the numbers are for adults, but you can, but weight for height square. So I think, yeah, that was this one, right? Yeah, what was it? Our CDC growth chart. Over there you can measure this, and even I think yeah, even our this one has it. I'm not particularly sure, but CDC, yeah, 100% they have it. Even ours have it. Yeah, it has it. Kanavati index, mid MUAC to head circumference ratio. Mild malnutrition is 0.28. So 3 numbers: 0.28, 0.314, 0.25. So 0.28 to 0.3, so from bottom to top will go. Less than 0.249, severe malnutrition, adjust number. So this is the number. So less than this is this thing. So 0.25, 0.28, remember it like, and 0.314. Yeah, these 3 numbers if you remember. Less than this, you put it in severe malnutrition. 0.727 is slightly less than this, so 0.1. So 0.27 comes under moderate malnutrition. 0.314 is the highest one, mild malnutrition. Mid upper arm circumference to head circumference. Kanavati index. Rouse or Singh's index, weight to height. Normal is 0.0015. Moderate is 0.00132. So 2 numbers to remember, 13 and 15. 0.0015 greater than that normal. Between that and the normal, this thing is moderate, and last one 0.0013. And we have come to the end of this nutrition section. These are the most important ones. There are more too. If you want, you can go over those, but right now it's these. Vitamin A deficiency. These are micronutrient deficiencies which include vitamins and minerals. So in vitamins we have 3: vitamin A, vitamin D and scurvy, and in minerals we have zinc. Vitamin A is a fat soluble which comes under A, D, E, K. Vision, immune function, epithelial integrity and growth. Vision, immune function, epithelial integrity and growth. So vision, can you remember the vision cycle, rhodopsin and all of that from physiology? Second one, immune function. Do you remember ATRA? ATRA used as a treatment of which one was it? I forgot. APML, acute promyelocytic leukemia. Why is that used? It's for maturation of cells. That is next one. Third one, same functioning of vitamin and maturation. It is for epithelial integrity, rapidly dividing cells, and growth, rapidly dividing. So by definition, growth is what? Increase in cell, increase in this one, division, cell division. So if you want that to happen properly, vitamin A is very important. Its deficiency in major public health issues, especially in developing countries. See, I'll close these things, okay? Otherwise, you know what will happen. This thing lacks the video. WHO, so preventable blindness, infection risk, poor growth. So same thing, derivative of this. So WHO staging. So we have some X's which form the primary signs and the secondary signs. So X1A, X1B, X1s are here, X2 is here, X3 is here. Then there's XN, XF, XS, XS. X1, X1A and B, conjunctival xerosis, Bitot spot. So B for B, Bitot spot. This one is fine. So Bitot spot, if you can't recall, I think you can recall. It's a very easy one. Otherwise, you can go and check. I can't recall it right now, but I'm not wasting time searching that because it's simple. Like, so the thing is, I'm doing this, it's a learning experience for me, and in case you want to do something similar, you can try it out, meaning as I tell. So I might sometimes I get an idea because the viewers might be at a different level. So in case that is the case, and if because streaming, don't really want to waste a lot of, it's not stream, it's recording. I don't want to waste a lot of time on extra things which I feel, because this is what I feel is important, so I'm focusing more on this. You might feel something else is more important. In that case, you can just write it somewhere and put it in the comments or something. It would be really nice. Yeah, coming back. So conjunctival xerosis, the first sign, X1A. No, it's not the first sign. I think it is the previous. These are the ones. Maybe somewhere here. These have it. Subclinical deficiency. But anyways, coming to classification, staging, X1A, X1B. So conjunctival xerosis, Bitot spots. So this is worse version of this Bitot spot. Foamy triangular plaques at the corneous krill. I wish I could put pictures here. Anyways, almost everything is copyrighted. Can't put it here. See, the thing is, the issue with copyrighted is after putting so much of effort, I don't want to be doing it again. I remove those pictures or website threats of the website being taken down and all that. So I didn't put it in the first place. I hope you can understand. But Google is available. You can just do one additional tab next to this YouTube video, and you can just search it, the term Bitot spot. You'll get the image. But it is obvious. It has been repeated so many times. Corneal xerosis. So conjunctiva is gone. Second, X2. The second stage is cornea is gone now. Now it is encroaching cornea. Cornea is getting dry. Dry cornea into keratinization. So keratinization is a compensatory feature to prevent further damage. But because of that, what happens? Vision is gone. Next one, corneal ulceration. So now there is more deficiency. What happens? Ulceration of cornea. Less than 1/3, greater than 1/3. So this 1/3 you can remember 1/3, and this is 3. Like fine, I think doable. Greater than 1/3, X3B, corneal ulcer. Next one, secondary signs. XN is N for night blindness, XF for fundal changes, XS corneal scarring, S for scarring. Next one, clinical features of vitamin A deficiency. So subclinical and clinical. So vitamin A, same thing. Impaired immunity, increased risk of measles, diarrhea, respiratory infections. Measles, diarrhea, respiratory infections. So remember, this is a part of NIS. So growth retardation due to poor cell differentiation. So as we have already discussed it, it is an important nutrient for growth. Ocular, night blindness, XN, X1A, it is for conjunctival dryness, dry and dull. X1B is for white foamy deposits, conjunctiva. Corneal cirrhosis is X2, X3 is 1/3 and greater than 1/3. What? Ulceration into perforation. Keratomalacia, severe softening and liquefaction of cornea leading to blindness. Softening of cornea is keratomalacia. Softening of bone, osteomalacia. Let's see. Osteomalacia is osteomalacia, softening of bones. Like, it's funny how, yes, so malacia means softening. Anyone knew that? It's fine. B, systemic features. Systemic overall. First we saw that just the eye signs. Systemic is growth retardation, stunting. So growth is affected, poor wound healing and recurrent infections. Because why? Because we have what is required for normal wound healing, proper epithelial function should be normal, and recurrent proper cell WBC functioning. Increased, same thing, infections, cell mediated immunity is affected. Skin changes, follicular hyperkeratosis, dry and rough skin. What is the management? Certain numbers again. 6 months, 1 year. Less than 6 months, 6 months to 1 year, greater than 1 year. Less than 6 months, so 6 months is 50% of 1 year, it is 50,000. 6 to 12 months is 1 lakh, so up to 1 year is 1 lakh, greater than 1 year is 2 lakhs. So this can be 2 years also, so it is 2 lakh for 2 years. Yeah. Next, maybe there is a way to do it via kg per this thing, but I'm not. No, it is 2 lakh IU every 6 months. That's prophylactic dose, but overall it is treatment. 3 doses are administered. First dose immediately on diagnosis. Dosage, this is the dosage. Second dose 24 hours later. Third dose is 1 to 4 weeks. So immediately on diagnosis, 24 hours later, 1 to 4 weeks later. That is almost 1 week to 1 month. 1 day, 1 week to 1 month. Severe PM, protein malnutrition, monthly vitamin supplementation until PM resolves. So PM, as we know, it encompasses both protein, energy, nutrients, other minerals, other vitamins and stuff that is required for growth. Prevention, prophylaxis, population based strategies, prophylactic dosing for healthy prophylaxis, and next one is in pregnancy and neonates. Overall we know it's required for growth, but overall in general for population based strategy it's different. For healthy children, because they are growing rapidly, it's different. Pregnancy and neonates, it's double. One is like mom and baby in the womb, and next one is neonates, like rapid growth, and these are very small. So first one, improved dietary intake of vitamin A. So this is primary prevention. Food fortification, vitamin A, fortified oils, periodic high dose. Infection control with measles immunization. So something that this exacerbates that exacerbates. So you prevent that, which is the complication of deficiency of this in the first place. That is this measles immunization. Next one is the measles. I need to make a answer on this too. I need to add it in the website. I haven't added it yet in my if my memory serves me right. I need to include it because it is somewhat important. It has turned important after last year's. The next one, prophylactic dose. First dose 1 lakh international units at 9th month with measles vaccine. So measles plus vitamin A, both go hand in hand. Second dose is 2 lakhs IU. So I mentioned it's cell mediated. Yeah, for that it is cell mediated, but in this case, maybe it serves a purpose. Not sure. Should I? No, it's fine. It is obvious thing to remember. Vaccine, measles vaccine along with vitamin A. Should I search it? No, I won't search it. I don't want to waste time doing more digging. Need to be exam specific. Like, it feels really nice looking at this. We have reached here. No, it's not actually. It's previous one. I go a little bit up. It still stays the same. It's fine. 2 lakh international units at 16 months, followed by 2 lakhs in 6 months up to 5 years. So 2 lakhs. Second dose is 2 lakhs at 16 months, or by 2 lakhs every 6 months up to 5 years. 16 months, which one is it? 16 months, it is 9 months is that. Okay, it doesn't come year wise. It's so 9 months, 16 months. That's how you remember it. Pregnant women, 10,000 international units per day supplementation. So per day it is 10,000. So where else did we see 10,000? As thousands, 50,000 in case of treatment, but here it is prophylaxis, that is 10,000 in case of pregnant women. Breastfed neonates do not require additional supplementation. So some things is like they look same, and confusion. I think there's a term for that in the memory related concepts. Some kind of there's confusion of terms that look similar. So sometimes you use both of them interchangeably. It's very confusing. Next, coming to vitamin D. So this is another fat soluble vitamin essential for calcium homeostasis, bone mineralization, immune function. So vitamin D, again calcium homeostasis, so immune function comes again. So deficiency leads to poor bone mineralization, causing rickets in children, osteomalacia. So malacia, and there malacia, here malacia. Softening, that is softening of what? Cornea. Here it is softening of bones. It is commonly seen in malnourished children, preterms, individuals with poor skin exposure. So in the Western countries they take vitamin supplements, vitamin D supplements. Malnourished children, preterm infants in India, malnourished. I doubt it is, if it is that common. It's rarely seen. Rarely meaning depending upon the geographical location it varies. Clinical features of vitamin D deficiency. Vitamin deficiency presents with musculoskeletal, neurological, systemic manifestation. So let's see. Yeah. So should we go to general features first, because we know it is skeletal features are involved, but general features we might skip it, like yeah something, but better to go through this first because we know those things are obvious, but these things we might miss. FTT, failure to thrive, poor growth and weight gain, lethargy and irritability. This is something you might not include. Protruded abdomen due to weak abdominal muscles. Okay, something framework is getting problems. Fractures due to poor bone strength, proximal muscle weakness, hypocalcemic symptoms, like other hypocalcemic symptoms like tetany, carpopedal spasm, seizures, hypocalcemia. So it's mainly related to the resting membrane potential and all that, extracellular, more negative or more positive. Not delving in more detail because that is more of physiology. Yeah, so this one is clear. Failure to thrive, lethargy, irritability, protruded abdomen, a fracture due to poor bone growth, proximal muscle weakness, hypocalcemic symptoms. Next, coming to proper skeletal, head and craniofacial features, craniotapes. Yes, I want to search this. Images. Yes, yes. Softening of bone. It's a ping pong ball. Very sad, but it's fine. Next one, frontal bossing. Prominent forehead. Frontal bossing. Frontal bossing. Yes, can you see frontal bossing? Frontal bossing. Yes, next. Delayed frontal closure. Skull mineralization affected. Persistent anterior frontal beyond normal age. Okay, frontal closure is affected. Craniotape. So in head region we are talking about craniotape is frontal bossing, delayed frontal closure. Next, delayed dentition, late abruption of primary teeth. So teeth are affected. So teeth, where are they? In the mouth. Where is mouth? In the head, near the head, in the face. Craniosynostosis. This one I need. Oh, anyways, we'll just finish this off, then take a break. This word, craniosynostosis. Like this, craniosynostosis. Something like this, something stepwise thing. Premature fusion of skull sutures. Yeah, maybe that is what causing abrupt. Is a closure of craniosystosis. Premature closure of skull sutures. Okay, so we are done with the initial part, the head and craniofacial features. Now after the break of 10 minutes we would be covering these, then we'll be going into other things. Okay, then where is it? Yeah, here is it. I'll turn the mic off and turn the camera off and come back after 10 minutes. You can also take rest. Welcome back. So we'll start with the next one. Yes. Yeah, so we in the last session we finished the head and craniofacial features. Now more into spine and other abnormalities. Spine and extremities, scoliosis, kyphosis, lordosis. So yeah, better to search this. So curvatures, it's always, not always, many times it gets confusing what scoliosis is, what kyphosis is, what lordosis is. Yes, yeah. So see, scoliosis is S from the front, kyphosis is like that, the thoracic curvature. Lordosis is the lumbar curvature. Okay, exaggeration. Enlarged wrist ankles, widened epiphysis. I don't know how it looks like. Wait a second. Yeah, so you can see this is interesting. Yeah, that's the one. By what is it? Windswept deformity, asymmetrical bowing of legs. This one. Yeah, fine. Windswept, like wind is sweeping the legs. Bowing of tibia and fibula, genu varum, genu valgum. Coxa vara, deformity in femoral neck leading to waddling. Coxa vara. Orthopedics, unless you look at it, it's very hard to imagine because even the names are slightly confusing. Coxa vara. See, 90 degrees should be like this. So deformity of femoral neck. See if the mic is on. Yes, it is. Deformity in femoral neck leading to waddling leg. Next, chest abnormalities. Rachitic rosary. We did appearance of, I think we have seen it. Did we see? Rachitic rosary. Coxa vara is 90 degree of femoral neck angle. Yeah, there was a nice image. Yes, this is the one. Harrison sulcus. Yeah, very interesting. You shouldn't say it is nice. It is interesting. Respiratory infections, poor ribcage development leading to atelectasis. Yes. Next, this one is done. Investigations. So lab investigations. So directly you do the vitamin D, and what does it affect? Physiological effects of vitamin D. Calcium phosphate, you check that. Physiological effects of vitamin D, ALP in the bones, and serum and parathyroid is related to this one. What is it? Vitamin D and urinary calcium. So deficiency 20 nanogram per ml. So three terms: deficiency, insufficiency, sufficiency. Sufficiency is greater than 30 nanogram. Deficiency less than 20. So 20 and 30. In the middle is insufficiency. Serum calcium and phosphorus. Hypocalcemia, hypophosphatemia. Serum ALP elevated in rickets due to increased osteoblastic activity. Why is it elevated? Why? Due to increased attempts to mineralize weak bones. So it's a compensatory mechanism. Yes, compensatory mechanism. ALP produced by osteoblasts help in bone mineralization by breaking up pyrophosphate. It's an extra, not required. I'll close this. Yeah. Parathyroid, secondary hyperparathyroidism, elevated PTH in response to hypocalcemia. So there is less of calcium. So body by itself, what does it do? Less of vitamin D, less of calcium. So one more pathway, that is PTH pathway, that is elevated. Next one, urinary calcium. So calcium is already low, but it is in the urine in normal states, but it reduces when you have vitamin D deficiency already. Next, radiological features, X-ray, wrist, knee, long bones. Wrist, we've seen the thickened wrist. Knee is playing this thing, windswept deformity. Yeah, everything you can see in this one. Long bones, it is something is different. Fraying and cupping of metaphyses. Yeah, pictures are really nice. Fraying and cupping of metaphyses. Yes, cupping. Yes, cupping. See, cupping. Fraying, what does the fraying mean? It's taking ages to load. Anyways, it is, yeah, here it is. So fraying, cupping. Fraying means, I think, a modified cupping. Coarse trabeculation of diaphysis. What does this mean? Coarse, yeah, diaphysis. Can see trabeculation is coarse. Trabeculations meaning those connecting the things that connect the bone, inside the bone. Generalized rarefaction, decreased bone density. Okay, so this is mechanical rarefaction. How do you see it in the X-ray? Maybe, yeah, you look at the density. Decreased bone density, it's visible on an X-ray. Increased distance between epiphysis, metaphysis. How does that look like? Yeah, epiphysis, small epiphysis, this is metaphysis. There is a gap, lot of gap. Yeah, so we have seen all the X-ray features. Growth plate widened due to defective mineralized. Should I search it? Yeah, better to search this one also. I'll finish it off. I think it's that only, epiphysis, metaphysis. Yeah, same thing repeated. Epiphysis, metaphysis done, fraying, cupping done, coarse trabeculation. Yes, you can, if you can imagine the X-ray. Generalized rarefaction, the density, you look at the density. X-ray of active rickets. Active rickets is something much different. Loss of sharp metaphyseal border. Okay. Cupping of metaphysis at distal end. Okay, already seen that. Thickening of growth plates. What does this look like? Thickening of growth plates. What is it? Rickets. X-ray. Okay. This one. That looks like the only abnormality. Okay, fine. Next treatment. Oh my god. This looks huge. So we'll break it down. Less than 1 month, 1 month to 1 year, 1 year to 18 months. Yeah, 1 year to 18 years. Okay. So 1000 international daily regimen, weekly regimen, STOS regimen, that is a high dose regimen, and maintenance dose. So what do we first we look at the daily regimen for each of these. That would be better. So 1000 international units per day, that is for less than 1 month. 1000 to 5000 is for 1 month to 1 year. 5000 for 1 year to 18 years. Okay, fine. Weekly regimen. So is it into 7? It is not. Is it IU per week? International unit to 12 week. Yeah, this is the same for everyone. Oh, 50, 50, 50. And STOS high dose is not available for this, not recommended. 1 to 6 lakh IU international units over 5 days. 3 to 6 lakhs over 1 to 5 days. 1 to 6 lakh, 3 to 6 lakh. Maintenance dose is same for the first two, 400 to 1000. Next one is 600 to 1000. You close your eyes, it's like 1 month to 1 year, 1 year to 18 years. Then you have daily, then you have weekly, you have STOS meaning high dose. Next one you have large maintenance dose. So first we look at daily is 1000 to 5000, then greater than 5000. In weekly you will get 50,000 for everything. And for STOS, right? Yeah, STOS, first one not recommended. Next two, what was it? 1 to 3 lakh, 3 to 6 lakhs. International units for 3 to 5 till 5 days or something. Yeah, next one I can't remember. Next one 400 to something. Yeah, 400 to 1000, 600 to 1000. 1 to 6 lakh, 3 to 6 lakh. This is 1 to 6 lakh over 5 days, 3 to 6 lakh over 25. Yeah, 400 to 1000, 400 to 1000, 600 to 1000. Yeah, per day. This is per day maintenance dose. Coming to general management, treat hypocalcemia. So what is the overall effect of vitamin D? Treat hypocalcemia, IV gluconate for symptomatic tetany, correct phosphate deficiency with dietary sources. So vitamin D, absorption of both calcium and phosphate, I think so. Yeah, there was this difference, vitamin D, absorption of both phosphate and calcium. Is it true? Yes, it is true. But for PTH, it is a phosphate excretion. So P for P excretion. Peeing P is for P. Peeing P is for PTH. Encourage sunlight exposure UVB for at least 20 to 30 minutes daily. Daily improvement. Increase intake of fortified milk, fish, egg yolk, green leafy vegetables. So dietary. STOS therapy. So we have seen it already. 1 to 6 lakh international units administered orally over 5 days. 1 to 6 lakh for 1 to 1 year to 1 month to 1 year, 5 to 6 lakh to 1 year to 18 years. Monitoring calcium, phosphate, ALP, X-ray, deformities needs to improve. So we are done with vitamin D2, D also. D2 means something else. Vitamin D2. Yes, coming to scurvy. Scurvy is it lagging? Yeah, okay, that is something. We'll search it just in one tab, and yeah, this is document for one thing, this one is for the document. Yes, scurvy is vitamin C. So leading to, it is vitamin C deficiency leading to defective collagen synthesis, impaired wound healing. So this leads to this. This also leads to this. Primarily affects infants, children, malnourished individuals who have inadequate dietary intake of vitamin C. So clinical features, early features, late features. Irritability and fatigue, which is generally seen due to impaired neurotransmitter function. So vitamin C can lead to impaired neurotransmitter function. That is something different. Loss of appetite, low grade fever, pseudoparalysis. So irritability, fatigue, loss of appetite, low grade fever, pseudoparalysis, knee and ankle swelling leading to refusal to move limbs. Scorbutic rosaries. That is rachitic, this is scorbutic. Rickets for rachitic, scorbutic for scurvy. Late features, skeletal symptoms, hemorrhagic manifestations, anemia. What does vitamin C leads to? How does it cause this? I think something related to the acid secretion and all that. Yeah, it was that. in the stomach, the acid secretion, it is the iron absorption is somehow linked with vitamin C. I remember something. Yeah, skeletal symptoms. Scorbutic rosary, wedge-shaped costochondral junctions with sternal depression. Yeah, we have seen that already. Gum changes. Yeah, gum, bleeding gums. Yeah, gum bleeding again. Yeah, repeated. Bluish purple, blue purplish discoloration with sweat, swelling, whitening of costochondral junction. Falcon spur. Falcon spur. What is it? Falcon spur. Interesting. Hemorrhagic manifestation. Petechia, purpura, ecchymosis at pressure points. Gum bleeding, poor wound healing, subperiosteal hemorrhage. And this one, these things. Yeah, radiological signs. Ground glass appearance of so defective mineralization. Pencil thin cortex and periosteal reaction. So due to pencil thin cortex, due to subperiosteal pencil thin cortex. Pencil thin cortex, where is it? Subperiosteal hemorrhage. So periosteum, pencil thin cortex. Yeah, Falcon spur. So hypovitaminosis. Yes, very nice. White line of Frankel, even that's here. White line of Frankel, I remember. Yeah, here. Dense zone of provisional calcification. White line of Frankel. This one done. Trummerfeld zone, scorbutic zone. Trummerfeld zone, yes. See, white scorbutic zone. Radiopedia. Falcon spur, we have already seen metaphyseal bony outgrowth. So, bony outgrowth from metaphysis. Falcon spur, yeah, this one. Yeah, if you remember this image, everything is clear. Next, Falcon ring epiphysis, Wimberg's ring sign, circular calcification around epiphyseal cartilage. Wimberg, maybe they have circled this. Radiographic features of scurvy. Radio subperiosteal hemorrhage, Trummerfield zone, same thing. Unmineralized zone, Trummerfield, black colored line. Falcon spur, extra growth. Rarefaction meaning less of white, that is black. Diagnosis of scurvy, clinical diagnosis, history of poor dietary intake, okay, pseudoparalysis, painful movement, okay. Radiological investigations, X-ray, okay, fine. Biochemical tests, obviously vitamin C less than 0.2. You remember vitamin D. Sufficiency, insufficiency, deficiency, 20 and 30. Yes. Leukocyte vitamin C concentration more reliable but difficult to perform. Leukocyte vitamin C concentration. Urinary excretion of ascorbic acid after oral supplementation. This is interesting. Management. Children, adults, different for both. Are we looking at adults? I don't want to look at adults because this is pediatrics. Maybe this would be helpful. This would be helpful in case of what is it? In case of medicine. I'm not sure if it's important. Scurvy is included in medicine. Next, 100 to 200. 100 to 200 in case of children, milligram per day. Symptoms improve with within 24 to 48 hours. 1 second. Sorry about that. Yeah, something came up. Yeah, coming back. 100 to 200 milligrams per day oral or parenteral. 100 to 200 milligrams per day oral or parenteral for 3 months. 500 to 1000 milligram per day for 3 months. This is for adults. 100 to 200 is like way less compared to what you give to the adults, but it is excreted in the urine. Yeah, it is excreted in the urine. That's why you measure this urinary excretion. Symptoms improve within 24 to 48 hours. Complete recovery within 2 weeks. That is quick. Dietary modification. Increase intake of vitamin C rich foods, which include green leafy vegetables, spinach and spinach, one name, fruits, citrus, papaya, mango, amla, guava, capsicum, green chilies, tomatoes. Supportive therapy, pain management, joint pain, blood transfusion is severe anemia, so iron absorption is affected. Physical therapy for muscle weakness. Prevention, milk fortification with vitamin C, dietary counseling for proper nutrition, routine vitamin C supplementation for high risk population. Cool. Okay, we are done with that. Next, last, zinc. Zinc, it's an essential element for vital for enzyme function. Yeah, enzyme functioning, I think, which is the enzyme? Carbohydrate anhydrase. Yes, it is. But the others too. This alkaline phosphatase, pancreatic carboxypeptidase. Immune response, wound healing, growth regulation, protein synthesis, cell division, normal development. So micronutrients is something we just think like vitamins, always vitamins. So micronutrients they also play a role. Look at the number of roles. Almost everything is covered. Functions. So ALP, carbonic anhydrase, pancreatic carboxypeptidase. Gene regulation, zinc finger proteins. So if you remember it from biochemistry, act as transcription factors for in RNA and DNA synthesis. Immune system modulation enhances T cell function, preventing infections, essential for T cell function. Zinc is for T cell, essential for cytokine production and antibody response. Cytokine production and antibody response. So it is not just cellular, it is also antibody. Regulate cell proliferation, required for fetal growth, bone development and puberty. So many things. Wound healing and tissue repair, this was well known. Facilitates epithelialization and collagen synthesis. Prevents oxidative stress and inflammation. Neurological functions such as synaptic plasticity, vitamin and brain function. Deficiency linked to infantile tremor syndrome. Infantile tremor syndrome. Rare condition, anemia and developmental delays. Yeah, this is one of the factors. This is reproductive health, supports spermatogenesis, testicular genesis. Yeah, hypogonadism, infertility is prevented. Dietary sources, animal sources, plant sources. And meat is everywhere. Liver fish, shellfish, egg and dairy product. I don't know how to remember all of this. I'm not. I'll write whatever comes to my if I get any kind of whatever comes to my mind. Yeah, that's what I'm going to write. So milk, meat, liver, fish, milk, eggs. That comes from most of them except the B vitamins. Most of the B vitamins are from other things. Yeah. Nuts, legumes, whole grains. I mean, this is similar to proteins, but nuts is specifically for micronutrients. Yeah. Zinc absorption is enhanced by proteins but inhibited by phytates. So phytates, if you can remember from physiology, it inhibits absorption of so many things, even so many drugs. Phytates, I want to know what these are. Do I know the names? Seeds, yeah, seeds, plant seeds. Yeah, don't consume plant seeds. Causes: inadequate intake. So fine, this one is fine, second one fine, this one also fine. Malnutrition, malabsorption syndromes, protein energy malnutrition, okay fine, this one fine, this one fine. Pancreatic insufficiency, okay. That one is something extra. Increased requirements: pregnancy, lactation, periods of rapid growth, infancy, adolescence, excessive losses, prolonged total TPN without supplementation, excessive loss, zinc loss in the urine, excessive sweatings. Genetic disorder, skip the first one. Prolonged TPN without supplementation. So yeah, when you are doing TPN, add zinc also. That's what they are trying to say. Genetic disorders: acrodermatitis enteropathica. So tips of zinc malabsorption leading to tips of fingers, acro meaning fingers are affected. Clinical features: growth and development is affected, and also hypogonadism, puberty is also delayed. Hepatosplenomegaly, that is out of nowhere. We haven't seen that after PM. In PM we saw that. What time is it? 4 o'clock. In PM we saw hepatosplenomegaly, hepatomegaly, splenomegaly, no, only hepatomegaly. Skin and hair disorders: periorificial extremity dermatitis characterized by red scaly. I need an image. Periorificial dermatitis. Okay. Red scaly. Characterized by red scaly pustula around mouth with eyes. This one is something new. Like you had those glossitis, what is that, other one, cheilitis and all that for other B vitamins, but periorificial and extremity dermatitis, that is something new. And we have seen the image right now. Alopecia, dry beetle hair, so hair is affected. Dry keratotic skin because of, not because, with, along with poor wound healing, immune dysfunction. So we have seen it's cell mediated and antibody mediated, both are affected, so increased susceptibility to infections. And this one, like usual. Neurological and cognitive effects: infantile tremor syndrome, we have seen this. Cognitive impairment and poor attention span, because it is involved in neurological functions, synaptic plasticity, brain function. What is that? Tremor syndrome. Yeah, same thing, tremor syndrome, infantile tremor syndrome. Hematological manifestation: microcytic anemia due to impaired iron utilization. No, previous one. GI: loss of appetite, anorexia. Microcytic anemia. This one, vitamin C, you have less of iron. I think vitamin C and HCl both are requirements. Yeah, both are required. Yeah, the thing was, only unless except in case of physiology and initial part of pathology, we never really go about vitamin C being necessary for iron absorption, which in turn can lead to anemia. So that is, vitamin C is somewhat left out, and we focus more on scurvy, not vitamin C, sorry, zinc. Yeah, zinc, this one is new. We are in a different topic. I need to know what this is. Zinc, does zinc and utilization, zinc, I never knew this. This is something new. Zinc leading to impaired iron utilization. Yes, why is that? Competition for absorption in the gut. Okay, so this is mainly high zinc levels, low zinc. No. Yeah, try again. And so iron motive, reduce substituent regulation, poor iron mobilization. Yeah, low zinc equals dysregulation of hepcidin. Yeah, hepcidin is affected. Pale skin, that is anemia related. So growth and development, skin and hair, immune function, neurological, cognitive, GI symptoms, hematological. Diagnosis, clinical diagnosis, poor diet, recurrent infections, we know some macronutrients. Presence of dermatitis, yeah, peri-orificial extremity dermatitis, characterized by pustular, red scaly pustular around lesions around mouth, eyes, genitals. Laboratory investigation, serum zinc level. I am not reading this. Tired of numbers. ALP levels low in zinc. Hair zinc analysis useful for long-term zinc assessment. Genetic acrodermatitis entropathica. This one not required. Management. Oral zinc therapy. Mild to moderate 1 to 2 milligrams per kg per day. This thing we need to do something. I just thought of something like an Anki for Anki deck for all the normal values, but the issue is it needs constant updating because of new guidelines and all that. But it's fine, somebody can do it. But even the first step, I'll have to do it. It will take a lot of time not doing that. I'll just go through this whatever the thing is to memorize, because it's not actually you need to know what the RDA, what the this thing number is, recommend the requirement, supplementation and all that, because it keeps changing. Not like generally it remains the same, but like I'm too lazy to create an Anki deck. I don't want to, but if somebody can, it would be really nice. Everybody could use it, and somebody can start another YouTube channel with a study with me Anki for RGUHS exams. That would be nice. Parenteral zinc therapy. There is one number here, 0.5 to 1 to 2 grams per day, milligrams per kg per day. Severe deficiency 3, 1, 2, 3. That's in 366 months. I'll drink some water. Zinc in acute diarrhea, 20 milligram per day for 10 to 14 days or greater than 6 months, 10 to 12 milligram per day for 14 days, children greater than 20 milligrams per day for 10 to 14 days. $10 milligrams per day for children, for infants less than 6 months. So 20 and 10 for greater than 6 months, less than 6 months. This is the division, 6 month mark in acute diarrhea. Probably it is coming somewhere down here, not here, here somewhere. Where is it? Diarrhea, watery diarrhea. Where did it go? Yeah, GI here, somewhere here. I was scared for a while, like, didn't I include diarrhea? Okay, then fine, it's in GI, not in infections. Okay, treating underlying conditions. A dietary modification, increased intake of zinc rich foods. So zinc rich foods, we already know what those are. Let's recall. I can't recall. Yeah, meat everywhere, liver, fish, shellfish, eggs and dairy products, nuts, legumes, whole grains, and phytates, that is plant seeds, keep them away. This one is done. Yeah, this one done. Yeah, phytate rich foods, yes. Again, treatment of underlying condition, PM malabsorption should be corrected. Prevention of zinc deficiency. Is the mic on? Yeah. That is the worst thing that can happen to you when you are recording. Mic off. Oh my god, I can't even imagine how I would be feeling in case the mic was off. Coming to prevention, the routine zinc supplement in PM diarrheal diseases, fortification of foods, zinc supplement. So for these 3 key points, I think it can apply to most of the most of the micronutrients, and most of the micronutrients you can just what do you say, in case something else comes up, for example selenium or something, just selenium has like it's less commonly asked, like it's not asked, never, they will never ask, but even if it comes up, like just modified version of this and just changing, like add meat everywhere, liver, shellfish and all that, I think you can make up some answer. Like they won't give marks, that's a different thing. They won't give a lot of marks, but they'll give something at least, because most of micronutrients have similar functions, like they have a multitude of functions, they are involved almost everywhere, but rarely like heroes we don't talk about. Breastfeeding. So we have reached a new chapter, now newborn infants, and what time is it? We have 14 minutes more. Let's see how far we can go. How many study with me is, how many 15 minutes today we can do a lot more. Let's see how far we can go. Yeah, breastfeeding, advantages, techniques and hazards of breastfeeding. Breastfeeding is a natural method of feeding infants and provides optimal nutrition, immune protection, bonding. Three things: nutrition, immune protection, bonding. Okay, the World Health Organization and UNICEF recommends for 6 months of life, and along with complementary foods up to 2 years. What are the advantages? So there are divided into 3. First one is advantages to the infants, for the babies: nutritional superiority, immunity and disease protection, reduced risk of diseases, brain development. So first one, provides ideal balance of proteins, fats, carbohydrates, vitamins and minerals. So everything easily digested and absorbed. So this is number 1, like it doesn't eat anything else, that is the only thing that it takes in, so that should be number 1. Number 2, immunity and disease protection, IgE antibodies, we all know, against respiratory GI tract. Why? Because it's mucosal antibody. Lactoferrin prevents bacterial overgrowth. There is some kind of antimicrobial property, E. coli and staph. Bile salt stimulated lipase, protects against giardia and amoeba. BSSL, giardia is also IgA linking to giardia. PABA, para-aminobenzoate against malaria. Malaria, yes, malaria in paper, one of the papers in second paper, I think it requires life cycle, which is a very important. I still haven't added that, so probably I'll keep the CDC malaria, I remember it, that is free to use. Malaria CDC life cycle, yeah, this one, this is the image, I think I can add. Yes, I'll save this now, and if I get time I'll just add it. This is a very nice image. I remember in second year they put up this image during lectures. Yes, reduced risk of diseases, lowers the risk of diarrhea, pneumonia, otitis media and allergies. So allergies, diarrhea, pneumonia, otitis media. So mucosal surfaces, yes, the same thing repeated. Immunity, breastfed infants have lower instances of childhood obesity, diabetes and cardiovascular diseases. So all the diseases in general. So first one it was infectious, second one chronic diseases. Next coming to prevents iron deficiency anemia due to better absorption of lactoferrin bound iron, better brain development. DHA, ARA. DHA, I think it was there in one of the advertisements. Which one? Pediasure. Yes, this is very interesting. I think let's see. Pediasure. Does Pediasure have DHA? No, it is not the one. Contain DHA. Yes, I remember once it used to come on TV. Pediasure with DHA. ARA, but this is something else. I just remembered the advertisement due to some reason. Just have the tab open. Yes. Benefits to the mother. Omega 3 rather than ARA, I think better to, this is easier to remember. omega-3 fatty acids. Benefits to the mother: postpartum recovery, stimulates oxytocin release, helping uterine contraction, reducing postpartum bleeding. Stimulates uterine release, helping uterine contraction, reduce. PPH, postpartum hemorrhage, is prevented because you know how the mechanism is. Like, if you want, you can search it right now in another tab. Like, the contraction of the uterus prevents the bleeding. Prevention of disease, lowers the risk of breast cancer, ovarian cancer, osteoporosis. Contraception effect. So this one, prevention of disease, is same thing from the previous one, but here this is female specific. Estrogen, this one, lack of estrogen. This one, let's see. Estrogen, yeah, estrogen is required for this one, right? The breast development in a pregnant female, and also after during breastfeeding and all. I think it maintains this thing, the breastfeeding part. So overall, it helps in that. Lactational amenorrhea, yes, suppression of ovulation. This is we learned in class 12th. Emotional bonding, enhances maternal infant attachment and reduces postpartum depression. Next, coming to societal benefits, healthcare costs are reduced. Yes, of course, because of all of this. Eco-friendly, no wasting, no this one, capitalistic endeavors are involved. Techniques, correct positioning of the baby. Effective feeding prevents complication, enhances bonding. So same thing. Correct holding position of the baby, correct attachment to the breast, breastfeeding techniques specific. Turn towards the mother, whole body support. Like, just imagine, yeah, this one, just imagine head and body in the straight line, abdomen touching the mother, and mouth facing the nipple and areola. Correct attachment, signs of good attachment, signs of bad attachment. So first we'll see the bad attachment: painful suckling, cracked nipples, frequent detachment, inadequate milk transfer. So if this is the thing, what can you do to prevent it? Lips everted, mouth wide open, chin touching the breast, this should touch the breast. A lower areola visible more than upper areola. So these are some key points. Like, hard to, I don't have a fetus, sorry, a baby with my hand, so I can't explain. I can't even show it because some point might be missing in a few of the images, so I don't see the point in even searching. There is a point, but how do you show it? You can't show it. It'll be like you need another dimension. Yeah. Breastfeeding techniques. Initiation: breastfeeding should start within 30 minutes of birth. Within 30 minutes. Exclusive breastfeeding for first 6 months. This point has been repeated multiple times. Rooming in, mother and baby should stay together 24 hours a day. Demand feeding should be breastfed 8 to 12 times a day. Types of breast milk: colostrum, transitional, mature milk. Colostrum, as you know, first milk 40 to 50 rich in IgA, proteins, immune factors, so immunity, confers immunity. Transitional, 5 to 14 days, increase lactose, fats and energy. Last one produced after 2 weeks, balanced nutrients for so that's why this one within 30 minutes you need to take it. The child needs to take it. Produced after 2 weeks, balanced nutrients for growth. Difference between human milk and cow's milk. So this is why you don't give cow's milk to a child, to a baby. Proteins are high, fine. Casein to whey ratio, this is different. Lactose, high in human milk. Essential fatty acids, see, this is where it comes in. Essential fatty acid, calcium phosphorus ratio, this one. And rest of this doesn't follow normally. Those are humans, those are animals. So the child is very delicate. You want proper homeostatic way of promoting its growth. Nutritional hazards of artificial feeding. So breastfeeding we have seen. Now artificial feeding, specifically what we are looking at. Nutritional disadvantages: cow's milk is nutritionally inferior, high casein content, harder to digest. Yes, high casein content. So you can see 80 is 20. Low essential, poor brain development, less IgA immune factors, infections. Yes, something to be kept in mind. Increased risk of infection, formula fed, increased risk of diarrhea, pneumonia, to contamination, otitis media, urinary tract infection, allergies and asthma. In case of formula fed, so allergies and asthma. That's what urban environment, more increased risk of asthma. It's not just the air, it's also the behavioral patterns that can affect how the bodies work. Yeah, environmental, formula feeding expensive, economic and environmental, requires bottle sterilization and clean water. Plastic water from this one can contribute. Plastic waste, not plastic water. Plastic waste contributes to environmental pollution. Emotional and psychological impact, reduced mother-infant bonding compared to breastfeeding. So we are done with the first part of newborn infant. Now coming to kangaroo mother care. This is so many times asked, like everybody asked about it, even in Viva. Kangaroo mother care, I think this thing came up in our last exam. Can't actually remember. I think this thing came up. Yeah, KMC, a specialized method of care for preterms and low birth weight infants, involving skin to skin contact between mother and the. I think if I do it a specific way, it just goes back. Newborn infants. In the 8th chapter, how many chapters are there? There are 32, and there are some really huge chapters like this. This chapter is really huge. This current chapter would be, is it? I can't actually tell. This is huge. This is really big. The rest of it, actually, since me personally, I can talk about myself. Since I have gone through medicine and all that, rest of these, most of these could go fast, but CNS it will be slower. Childhood malignancies, there are some like ALL. Anyways, let's see. The idea is to finish as many things as fast as possible with lot of comprehension. Not it won't be. I'll try to make it as amazing as possible. The most amazing video lectures ever. These are not video lectures. This is an active learning method, wherein it's like a real-time Feynman method. Like I coined the term. So in this, should I talk about it after 2 minutes? Yes, I'll talk about it after 2 minutes. I'll continue with this. Yes, KMC, mother and the baby, the contact, and it is alternate and incubator care for low birth weight, but has now become a standard practice in neonatal. So incubator care, which was there for low birth weight infants, but currently even for normal infants it is there. It is the normal method of initial mother to child bonding, not bonding specifically, other things are also included. But when you see kangaroo mother care, first thing that comes to your mind is the bonding, increased bonding, but that's not the only thing. There are many other things. So what are the components? Kangaroo position, kangaroo nutrition, kangaroo discharge and fall. I never read these headings. It's kangaroo position, kangaroo nutrition, kangaroo discharge and follow up. So what is kangaroo position? Skin to skin contact between mother and infant. Both are in vertical position. Infant is placed between mother's clothes between her breasts. Mother remains in semi-reclining position, preventing gastric reflux. The position is maintained until infant refuses or shows discomfort. So the limiting factor is the child's behavior. So next, coming to everything is self-explanatory, so you can easily imagine it, so I don't have to delve more deep into it. Kangaroo nutrition, exclusive breastfeeding is encouraged. That is very important. We have seen it repeatedly. Holding the baby near the breast stimulates milk production. If direct breastfeeding is not possible, expressed breast milk is these things. These are the extra things. Palladi. What is palladi? Yeah, something. Bonla. Palladi. It's a Hindi word, I think. I don't know how it's pronounced. That's fine. a tube feeding if necessary. So nutrition is done, so position is done, nutrition is done, kangaroo discharge for early home discharge in kangaroo KMC position. Parents are counseled how to continue KMC position at home. So that is what it means. So it's just to keep that in mind, you place it here, so that after discharge also you need to continue. Regular monitoring of weight gain, feeding and temperature is necessary. Okay, fine. So clinical benefits. So why is this necessary? Because these are the things that KMC contributes to. Clinical benefit: thermal regulation, see temperature, prevents cold stress, hypothermia in preterm infants, improves thermal protection. Yes, let's start this break and close this. Yeah, what was the topic I was talking about? I forgot. So the moment it comes up in your head, you need to, like, for me at least, I need to talk about it, otherwise I'll forget about it. Now I can't talk about it. Yeah, so where are we right now? Yeah, after a particular point in time, it is just medicine. I think this is neonatology, growth and development mostly. It is done. Neonatology is the one. Yeah, I'll turn off the camera. You can take rest, and I'll take some rest. Then we shall continue after 9 minutes. Yes, coming back, third session. So, yeah, thermal regulation improves thermal production and homeostasis, which is obvious, like looking at what the position of the baby and the mother is. Improved growth and weight gain. Continuous KMC promotes better feeding efficiency, enhances caloric retention and weight gain. Reduced infections and weight gain. So promotes better feeding efficiency and weight gain is promoted. Reduced infections, improved immunity. It reduces the infections of respiratory tract and nosocomial infections. Breast milk transfer during KMC enhances passive immunity. So this is somewhat advantages of breastfeeding itself, but maybe in this particular position it's different. Shorter hospital stay, there's early discharge, better physiological stability, so heart rate, respiratory rate, oxygenation, sleep patterns, everything is better. Emotional bonding strengthens mother to mother child attachment, reduces maternal stress and postpartum depression. Eligibility. Which one is this? I think this one is done. Yeah, all this KMC procedure. Wait. It's a position. Yeah, eligibility criteria. Yeah, okay. Okay, this was in brief. This is properly what it is. Yes, makes sense. In what is the eligibility? Infant hemodynamically stable LBW can tolerate KMC sessions increasing gradually, can be provided. Baby is fed via organic tube, CPAP or supplemental oxygen. Okay, so it is specifically for hemodynamically stable low birth weight babies, but it now becomes standard practice. So probably it's for LBW only, low birth weight, but okay. Yes, coming back. Maternal criteria. All mothers can provide KMC irrespective of age, parity, socioeconomic status. Should be clinically stable with no active infection. If unavailable, father or another caregiver can provide KMC. KMC procedure. Positioning. Baby is positioned upright between the mother's breast, head turned slightly to one side, extended to keep airway open, extended. Hips are flexed, so hips are flexed like a frog and abducted. So the frog's position. Baby's abdomen should be at the levels of mother's epigastrum, gastrum meaning stomach level, just below the diaphragm, near the diaphragm, midline. Mother's breathing stimulates the baby, reducing apnea, and support the baby's bottom with a sling or binder. Let's just search how it looks like. KMC position. Yes. Interesting. Regular checks during initial stages, ensuring infant's neck is not fully flexed or fully extended. Monitor for regular breathing, pink color, stable temperature. Duration. Start with short sessions and gradually increase duration. Continuous KMC is encouraged, especially for very low birth weight infants. Mother can sleep with the baby position, with the KMC position semi-reclined, 30 degrees. When to stop KMC? KMC is continued until the baby tolerates it. Baby cries or fusses, KMC may not be required. So until the baby wants to change, behavioral change is noticed. If the baby cries or fusses, KMC may not require. May not usually start when the baby reaches 2000. Yeah, it's for lower birth weight infants, LBW. 2.5 kilos. Where did it go? Yes, here. Challenges: maternal fatigue, prolonged KMC can be exhausting, limited privacy, social and cultural barriers, need for family support. Yeah, so this one is fine, KMC is done. So going to the next one, neonate. Definition of neonate: newborn infant up to 28 days of life. This period is critical for survival and essential and highly susceptible to infection, prematurity related complication and birth injuries. Yes. Classification. So different based on the this one, what is it? So this is a short one. Definition and classification. Classification based on gestational age. Finish it quick. Yeah, premature, less than 37. Less than 37 premature. Term is 37 to 42. 37 to 42. Greater than 42 is post term, and post dates is greater than 40. 37 to 42, greater than 42. Greater than 40 is separate term altogether. Preterm neonates have increased risk of respiratory distress syndrome, RDS, because of lung maturity being impaired. Immature lung immaturity. Hypothermia, feeding difficulties. Post-term risk of meconium aspiration syndrome and birth trauma. Okay. So the clinical clinical significance of that. Based on birth weight, low birth LBW 2.5, less than that. Very low birth VLBW less than 1.5. I want to see how it looks like. LBW baby. Look at this. The LBW baby less than 1 kilogram. It's like how heavy? Like very light. The classification based on weight for gestational age. Small for gestational age, less than 10th percentile or less than 2 standard deviation below gestational age. Appropriate for gestational age. So based on the centiles again, 10th and 90th appropriate. Large is greater than 90th or 2 standard deviation. So large is 2 standard deviation is taken as the mark. Small is less than 2 standard deviation. Between 10th and 90th, which is between these, is appropriate. Aging infants increased risk of hypoglycemia, hypothermia, growth retardation, which is similar to preterm. Large gestational age, birth trauma, shoulder dystocia, and what was the other one? Neonatal hypoglycemia seems to be common. Yes, coming to neonatal jaundice. Yellowish discoloration of skin and sclera in newborns due to elevated bilirubin levels. Common conditions affecting neonates with approximately 60% of terms, 80% of the preterms. Very common. So while knowing this is very important. While most common cases are benign, 5 to 10% develop pathological jaundice. So whoever gets these 60% of these, 80% of these preterms, out of these 5 to 10% have pathological jaundice. So what is pathological? So pathological we have here pathological cause. Meaning it can go on to, it can be anything. Yes, I think it can be anything. So physiological cause, let's see this, and pathological causes. We'll go through the causes, then we'll think about it later. Physiological cause: increased bilirubin production due to high fetal RBC turnover. HbF is the key. Immature liver enzymes leading to decreased bilirubin conjugation. So liver is immature, enzymes are immature. So conjugation is affected. Increased enterohepatic circulation of bilirubin. So gut is getting active right now. So with that you have increased enterohepatic bilirubin. Next, coming to pathological causes: increased production, increased uptake and conjugation, enhanced enterohepatic circulation, and miscellaneous causes. So increased bilirubin. So this is similar to what is that? Similar to hemolytic jaundice. So hemolytic jaundice, blood incompatibility, RBC membrane defects. You know how it happens. Like this is immune. You have this passing to you. It's not able to ruptures easily. RBC enzyme defects. So membrane. So because of this, RBC is not qualitatively good. because of this one is membrane is not good. In this particular case, the immune antibodies, and that leads to hemolysis. Infections, that is torch, sepsis, malaria, congenital malaria. Polycythemia, delayed cord clamping, which is the cause. Impaired bilirubin uptake and conjugation. There is Gilbert syndrome, its uptake is bad. Crigler-Najjar 1 and 2, UDP glucouronyl transferase. UDP glucouronyl transferase, that is Crigler-Najjar 1 and 2. One of these is, I think one is asymptomatic or mild, and 2 is very bad. Yeah, something like that. One is deficient, other one is absent. Absent is much more worse. Enhanced enterohepatic circulation, small large bowel obstruction. So this was over there somewhere. And miscellaneous, which is prematurity, sepsis. Polycythemia, infant of diabetic mother, cephalomota. That's what, you can't put it anywhere, and it's not so obvious when you look at it for the first time. But infant of diabetic mother have they have high RBC, here, high RBC in polycythemia. Sepsis, I think mostly related to that what is that, microangiopathy, hemolytic anemia, prematurity not particularly sure, but prematurity is, prematurity almost causes so many things, and overall so many complications with that. Cephalhematoma and bruising, with increased RBC breakdown, obstructed labor and all that. Pathogenesis, bilirubin produced from breakdown of hemoglobin in RBCs is transmitted to liver and is bound. When it's bound to the albumin, and then it is transmitted to the liver. Liver enzymes conjugate bilirubin into water soluble form. So conjugated bilirubin equals water soluble, and it is excreted in bile, then into the intestine, and it's either excreted or reabsorbed via enterohepatic circulation. It's in pathology, bilirubin production is excessive, conjugation, excretion is impaired or dangerous, leading to the hyperbilirubinemia, which is quite dangerous. So classification of neonatal jaundice, we have two main, based on the onset, based on the type of neonatal jaundice. Based on onset, it is less than 24 hours, 24 hours to 72, which is 72 how much? 48 is 2 days, 36 is 3 days, 4 days, 4 days, right, 24 into 4, it's 96. How many hours is it? Calculator. 24 into 4 is 96. Almost 3.5 days. Not 3.5. No, sorry, 3 days, 3 days. 72 is 3 days. Yeah. So incompatibilities, torch infection, sepsis and congenital malaria, that is less than 24 hours. 24 hours to 1 day to 3 days. Physiological jaundice, which we are going to discuss more about here. G6PD, sepsis, polycythemia. Sepsis has been repeated twice now. Sepsis again down. Intestinal obstruction, which is in breast milk jaundice, is here. Physiological jaundice up here. Breast milk jaundice, UTI, hypothyroidism, intestinal obstruction. So few causes everywhere, I think should be good enough. Type of neonatal jaundice: physiological, pathological, breastfeeding, breast milk. Physiological appears after 24 hours, so see 24 to 72 hours. Peaks at 3 to 5 days, resolves by 2 weeks. Peaking at almost less than a week, resolves by almost 2 weeks, and peak bilirubin is 13 mg per deciliter. Pathological jaundice appears within 24 hours. So this is the first section. Persists beyond 2 weeks, and peak is greater than 15 milligrams. So it is less than 13. Here it is greater than 15. Breastfeeding jaundice occurs in first week due to low milk intake and dehydration. Feeding is impaired. Breast milk appears at 7 to 14 days, peaks at 2 weeks. and this due to unknown factor in breast milk. Appears 7 to 14 days, peaks at 2 weeks due to unknown factor in breast milk. So breast milk is causing the jaundice here. Here lack of breast milk is causing the jaundice. So which one should improve with more breastfeeding? The first one. Which one should get worse with breastfeeding? The second one. So when does it appear? This one is first week. This one is between first and second week. So peaking at 2 weeks. What are the clinical features? Yellow discoloration of skin and sclera, lethargy and poor feeding, hypotonia, high-pitched cry, kernicterus opisthotonous position, which is, if you remember from, I think, strychnine, one of those. Normal muscle and tone and seizures, hearing loss, neurodevelopmental delay. Kernicterus. Clinical assessment, which is Kramer's rule. There are different zones in the body which show different levels. So just by looking you can tell. Not sure if it is still relied upon, but fine. Bodies of a face. If face is involved, 4 to 6 milligram per dl. Upper trunk, like chest region, it is 6 to 8. Lower trunk and thigh, 8 to 12. Arms and legs, that is extremities, it is except the palms, it is 12 to 14, and if palms are also involved, palms and so 15. So if you see it multiple times, I think doable. Like remembering shouldn't be hard. 4, 6, 8, 12, 14. 4, 6, 8, 12, 14. Management. Frequent breastfeeding to promote bilirubin excretion. Okay. 12 to 14 feeds. Monitor bilirubin levels every 12 to 24 hours. Phototherapy. Mainstay of treatment. Uses blue light to convert unconjugated bilirubin into water soluble form that can be excreted in urine and stool. Uses blue light, so unconjugated to becomes conjugated. Conjugated meaning water soluble. So there are two different types. So this by itself, this entire thing it's a 3 marker. They can also ask it as a 5 marker. So whatever it is, you can expand, you can write about this. So now you know. Conventional phototherapy, standard light exposure, intensive phototherapy, high intensity for they're conventional. Normal one is usually done. Intensive is high intensity for rapid reduction. Where it is excreted? In the stools and urine. Side effects: dehydration due to insensible water loss. So you are throwing in a lot of conjugated bilirubin inside the urine, and what happens? You are losing a lot of water. Bronze baby syndrome, rare, seen in conjugated jaundice. So conjugated meaning post-hepatic. Loose stools and rashes. Yes. Exchange transfusion. Double volume exchange transfusion, DVET, indicated in severe hyperbilirubinemia, reduces excess bilirubin, and indicated in severe hyperbilirubinemia, removes excess bilirubin, sensitized RBCs when done when TSB greater than 20 milligram per deciliter. So soles and this thing when is at 15. So way beyond that. In term neonates, in preterm it is 10. So where does it appear? Here in this section, lower trunk and thigh. So greater than 10 for sick preterm, and for normal neonate it is greater than 20. Side effects: hypoglycemia, because you are transfusing and you lose glucose. Hypocalcemia, everything goes, and sepsis. What I am thinking of is something related to this one. What is that? Infection from the procedure itself. Could be anything. Yeah, medical treatment. Oral phenobarbital induces UDP this is something new. Induces UDP glucuronal transferase for bilirubin conjugation. Phenobarbital, heavy metal chelators, inhibits heme oxygenase, reducing hemoglobin breakdown. Heavy metal chelators. Okay, one of the steps of heme breakdown is inhibited with heavy metal chelators. So, 2 drugs, oral phenobarbital, heavy metal chelators. Next, neonatal sepsis, also important. Neonatal sepsis refers to systemic infection in newborns due to bacterial, viral or fungal pathogens. 3. Include septicemia, pneumonia, meningitis. Early diagnosis and treatment very important to prevent complication mortality. Not looking at this, not even this. Major organisms, yes. E. coli, Staph aureus, Klebsiella, Acinetobacter, Pseudomonas. E. coli, Staph aureus, Acinetobacter, Klebsiella, Acinetobacter, Pseudomonas. Etiology. So, multiple etiologies. So, classified under bacterial, viral, and we have risk factors. Yes, yeah, bacterial. Let's see what the E. coli, Klebsiella, Pseudomonas. Okay, gram negative, group B gram negative. Those are gram negative. Gram positive, we have group B, Streptococcus, Staph aureus, coagulation negative, Staphylococcus. Which was that? I can't recall. Fine. Viral causes. I don't have the energy to search. Viral causes. CMV, first trimester transmission, most severe. Herpes simplex virus leads to disseminated neonatal infection. Rubella, toxoplasmosis, syphilis, varicella. Risk factors. Maternal and neonatal. Maternal includes prolonged rupture of membranes, maternal fever, multiple vaginal examinations, foul smell like. So basically anything that can cause infection like to the tract, genital tract. So prolonged rupture of membranes, which is equivalent to 18, greater than 18, or multiple vaginal examination, maternal fever, the risk factor. Foul smelling like. Then neonatal factors, low birth weight, prematurity, immune functions. That is what I think we are looking at. Poor wound care, yes, needle pricks, lack of breastfeeding. Coming to pathogenesis. Colonizations of skin, umbilical stump, nasopharynx, conjunctiva or respiratory tract. Transient bacteremia, gain access to the bloodstream. Okay, invasion of bloodstream leading to dissemination to multiple organs, the lungs, pneumonia, and there are multiple other regions. So first there is colonization, bacteremia, colonization, then from the local side it goes into the blood. From the blood it goes to distant multiple organs. The organs include lungs, meninges, metastatic foci. Yeah, metastatic foci include septic arthritis, osteomyelitis, DIC shock. So classification: early onset, late onset. Early onset is less than 72 hours, which is 8th one. Okay, fine. Early onset less than 72 hours. Group B Streptococcus. Should we know about this? Should be confusing actually. Like early onset, late onset. I'll be just sticking with this because this was included previously. If I put in again, like I don't know if I would be able to remember this. Like in case can do it, you do it. But I'll be just looking at early onset, late onset, less than 72 hours, more than 72 hours. Maybe it is required, yeah, because this one is mainly hospital acquired. Candid and staff I think also hospital acquired. Since only Pseudomonas. No, it's very difficult to. Is there any logic to this? Only then it is possible to remember. Is there any logic to this, to these organisms classification? Logic based on the time of onset. Mother to baby. Oh, delivery. Okay. E. coli common during okay. Contaminated food. Lepsius in hospital settings. Okay. Late onset. Hospital transmission. NICUs. Okay. We have staph aureus. Pseudomonas nosocomial. Yes. Candida. Yes. Makes sense. I'll add this somewhere. So I'll copy this. Probably I'll end this thing. What is it? What do you say? The study with me thing right now. Like after 24 minutes, like this would be one video. Then after a while, I'll take a good amount of break. Then I'll come back with another one. I'll finish that and upload that also. So 2 study with me, 3 hour long per day. Yeah, for now. Let's see how. For now, like after 3 hours, it's very difficult. 10 minutes break for me. Where is I'll add it as the next tab. So I'll change this thing PEDS 2. That was the PEDS 1, the earlier one that I sent. I've added it in the description in case you want to go through the previous video. As early onset acquired during, it was here itself, hospital and community. So hospital, this is a hospital or community, so mainly hospital. This one is genital tract, maternal genital. Why did I go there? Fine. That's what happens when you keep on doing that, right? Like, despite Pomodoros or anything, you can't do it 100%. You can't go on and on even with Pomodoros. You need a longer break after 3 hours. I need a break. Might be different for different people. That's the case for me. Clinical features of neonatal sepsis: non-specific signs, poor feeding lethargy, temperature instability, irritability. Okay, non-specific signs of this. This is general features. So it could be either fever or hypothermia, irritability, hypotonia, weak cry. Okay, fine. Organ specific: septicemia, poor perfusion, hypotension, tachycardia, abdominal distensions, vomiting, apnea, pneumonia, there is fast breathing, chest retractions, grunting, meningitis, there is high pitched cry, seizures. Okay. So general features of pneumonia, you write the most common ones. So we are going in more depth in the later chapters, like CNS, we have meningitis, very nicely given, respiratory pneumonia, very nicely given. Yeah, so that would be going there. Answering this question would be very easy. Features of severe sepsis. This one is fine. What is that? General, from medicine and surgery, it's obvious, all these things, general features. So non-specific signs, these are the things. This is what you will have to put it in more with additional effort. Rest of the things, it's actually doable if you remember the definition. Investigations: blood culture, gold sensitive, everywhere. Total glucose count, TLC less than 5k, greater than 15k. Either of these, not just one side. It could be this one also. Absolute neutrophil count, that's what, 1.8k, less than that it is immune suppression. So we have seen leukocyte and ANC, neutrophil count, and CRP, inflammation greater than 1 mg per dl, lumbar puncture, suspected meningitis, urine culture, micro-ESR greater than 15 millimeter per hour. Management of neonatal sepsis: supportive care, temperature, temperature, it can be hypothermia or hyperthermia, right? So either of them. Oxygen therapy for respiratory distress, IV fluids and electrolytes, and antimicrobial therapy. Antimicrobial therapy, this one is general supportive care. Blood transfusion, IV fluids, oxygen therapy. Antimicrobial therapy, that is first line, second line, third line. First line, ampicillin is the penicillin, it's aminoglycoside. Is it aminoglycoside? Yeah, isin is aminoglycoside, I think. It is an aminoglycoside. Yes, it's an aminoglycoside, because sometimes it is. It's a silly thing, but yeah, it's penicillin or an aminoglycoside. Next one, cefotaxime, cephalosporin. Even this one is this one, right? Amikacin, amino. Is it? No, it is something else. Even that is an aminoglycoside. Isin, amikacin. So sorry, these are silly things, but sometimes it gets confusing. No, only that aminoglycoside part. This for anaerobic infections. For resistant strains, clindamycin is added. And then third generation. So here we have cefotaxime also. Cefotaxime, which generation? I can't recall. Fine. Third line treatment, cefotaxime is repeated again. Vancomycin, amikacin. Yeah. So clindamycin goes off, vancomycin comes up, ampicillin goes off, cefotaxime comes up. Prevention: hand hygiene, sterile cord care, exclusive breastfeeding to boost immunity. Complications: shock and MOTS, multi-organ dysfunction. Meningitis can lead to its complication, which is neurodevelopmental delay, hearing loss, septic arthritis, osteomyelitis, which is distant. These are some of the distant organs which are more affected. What was it? What was the term used? There was a term, metastatic foci. Those are the metastatic foci. And then there is DIC. DIC is pretty bad. Early diagnosis. So early diagnosis very important, and aggressive antibiotic therapy. Long-term complications based on severity, duration, and the site that is most affected. That is the end of neonatal sepsis. Now RDS. This is only thing that comes to mind is prematurity and immature lung and LS, lecithin sphingomyelin ratio. Okay. RDS is known as hyaline membrane disease. Hyaline meaning proteinaceous deposits in the alveoli. It leads to it is seen in preterms. It causes respiratory failure, and it is due to surfactant deficiency resulting in alveolar collapse, impaired gas exchange, and progressive respiratory distress. And mortality can exceed 50%. That's why this is a very important topic. Etiology: prematurity less than 34 weeks, surfactant deficiency leading to alveolar collapse. So surface tension, it reduces with surfactants. Yeah. So you need to have reduced surface tension. For that you need a lot of surfactants. But if you have less of surfactant, there's more of surface tension, and the surface tension leads to the collapse of the alveoli. Maternal diabetes mellitus, because insulin inhibits it, the surfactant synthesis. Perinatal asphyxia leads to pulmonary vasoconstriction and impaired surfactant function. Caesarean section without labor. Lack of catecholamine surge delays lung fluid absorption. So you need catecholamine surge, which comes only with labor. But if you don't have that, in case of C-section, lung fluid absorption is delayed. And which is the brain? Yeah. So pulmonary vasoconstriction needs to dilate with oxygen coming in there and all that. If there is no oxygen coming in, the pulmonary vasculature will stay constricted. It won't dilate. Multiple gestations, increased risk due to preterm. Pathogenesis: surfactant deficiency, hypoxemia or hypoxemia, hypercapnia, pulmonary vasoconstriction, hyaline membrane formation. So surfactant deficiency. Surfactant is produced by type 2 pneumocytes, starts at 20th week of gestation, peaking at 35 weeks. So 35 weeks, like that's a lot of it happening. But if you deliver before that, it's over. It's not over, but it is less. Function reduces alveolar surface tension, preventing collapse during expiration. Deficiency leads to alveolar atelectasis, low lung compliance, and impaired gas exchange. Okay. Yeah, so step by step, atelectasis, compliance is reduced, impaired gas exchange, or overall it is that. Poor ventilation causes retention of carbon dioxide, respiratory acidosis, hypoxemia worsens due to alveolar collapse. So the first point, it worsens this one. This worsens the collapse. Pulmonary vasoconstriction, this is another one. Right to left shunting occurs through foramen ovale and ductus arteriosus, leading to persistent fetal circulation. So this one, what is it? Pulmonary vasoconstriction, meaning a lot of pressure in pulmonary circuit. Lot of pressure in pulmonary circuit meaning lot of pressure in the right heart. Lot of pressure in the right heart equals more blood from right heart to left heart through that hole, foramen ovale, which is equals to persistent fetal circulation. Hyaline membrane formation. Progressive epithelial endothelial injury leads to proteinaceous exudates leading to hyaline membrane. Something similar happens in kidney also. Like one of the diseases, which one was that? Hyaline arteriosclerosis, hypertension mostly. Yeah, there also epithelial endothelial injury. Clinical features of RDS: onset within first 6 hours of birth. Symptoms: tachypnea, which is respiratory rate greater than 60, grunting due to forced expiration to keep alveoli open, grunting, retraction, cyanosis, diminished air entry. Severe leads to respiratory failure. What are the scoring systems? There is a scoring system, Silverman-Anderson score. Assess work or breathing. Silverman-Anderson scoring. Diagnosis: chest x-rays and shake test. Chest x-rays, low lung volumes, air bronchogram, reticulogranular pattern, whiteout lung in severe fields. In severe cases, low lung volumes, air bronchogram. So chest x-ray findings, let's just search this up. X-ray findings, RDS, distress, yeah. Is there any explanation for all of this? So whiteout. What is air bronchogram? Collapsed alveoli, air-filled bronchi. I need some kind of. There was a nice image. Yes, bilateral symmetrical diffuse ground glass, low volumes, bell-shaped thorax, severe cases, whiteout lungs. Okay, fine. I've seen some points. Reticulogram. Shake test: mixing amniotic fluid or gastric aspirate with ethanol. Amniotic fluid or gastric aspirate. Okay. Foam layer at air liquid interface. Air liquid interface. This is adequate. So surfactant, it's basically fat. So fat and foam is somewhat similar. So between air is up here, liquid is down. Between that you have that foam layer. Shake test, we need to say this. This is a test, not in the lungs. I was thinking in terms of lungs how it looks like. Shake test. Here there is very nice positive gastric aspirate test. Wait, what is it? Examine the gastric aspirate. That no. Negative, there's nothing here. Here see foam. Can you see it? Yes, you can. Next, sorry if I speak like that. The thing is, it is tiring. Just 10 more minutes. Just finish it off. Then I'll see. During the break, I'll decide if I want to make it 20-minute session, 25 minutes plus 5 minutes or something of that sort. Or I'll just stop this right now, or and get back to this after a longer break. I'll see. So think about it, because I really want to finish this as soon as I can. Management of RDS, supportive care, respiratory support, surfactant therapy, antenatal steroids. Yeah, these are the main things, and then there is prevention. Yeah. So the thing is, this one is easy to remember actually. This one, because this is obvious. This is deficient, give this. But other things also very important. Maintain warmth. This has been repeatedly. It's preterm, maintaining the temperature, maintaining warmth to prevent hypothermia. CPAP, nasal prongs and ventilator to maintain oxygen saturation levels, IV fluids and electrolytes, correct acidosis and hypotension. Then there is respiratory support. Early CPAP reduces the need for intubation. You don't have to intubate if you give early CPAP. Mechanical ventilation, severe cases. Early CPAP, mechanical ventilation, two important points. And then surfactant therapy. So prophylactic 15 to 30 minutes in less than 28 weeks neonates. Rescue therapy within 6 hours of moderate to severe RDS. And then methods, there are different methods. One is mist, ensure, intubation, surfactant, extubation. Intubation, surfactant, extubation, ensure. Like this is minimally invasive surfactant therapy, mist. Antenatal steroids given to pregnant women between 24 to 34 weeks of gestation to enhance surfactant production. So betamethasone, dexamethasone, and first one is 2 doses, next one is 4 doses, 12 hours apart. This 12, so that's why you have this half of this. So here it doubles and the duration reduces by half. You can see it here. Prevention, antenatal steroid to reduce the risk of RDS by 51, avoid unnecessary C-section. CPAP to reduce this one. This one I added additionally actually after I thought about after adding that later on. So this is somewhat very important. Antenatal assessment of lung maturity. So in case of preterm infants, you need to determine whether prophylactic therapy or whether it's required or not. So how do you do it? So there are multiple tests, multiple methods to assess. One is LS ratio, phosphatidylglycerol. Then your lamellar body count, a foam stability index, which is we have already seen the foam layer between the liquid and air. And then lecithin, LS ratio. LS ratio greater than 2 is good, less than 2 is bad. And in lecithin, phosphatidylcholine is the major component and sphingomyelin is the S for LS. Phosphatidylglycerol appears at 35 weeks of gestation in the amniotic fluid. Presence of phosphatidylglycerol confirms lung maturity. More reliable than LS in IDM. Diabetes mellitus. Let's check what that is. What is IDM? IDM. GDM I know. IDM. Impaired infant of diabetic mother. Yeah, I'll change this. Infant of diabetic mother. It's directly from the textbook. It's fine, no problem. Infant of diabetic mother. Lamellar body count. Surfactant stored in type 2 pneumocytes. Okay, type 2 pneumocyte, the producers of surfactants, greater than 50K lamellar bodies per microliter indicates lung immaturity. Lung maturity greater than 50K. 50K is the number. And from this one we have already spoken. Complications: acute and chronic, acute and late. Acute is pneumothorax, air leak syndrome. How is that? What's the mechanism? Patent ductus artery. Yeah, this one is fine. I already explained. Hypoxia induced intracranial hemorrhage. How does this happen? How does RDS cause this? Due to underlying lack of overdistension. Okay. Increased work of breathing. Okay. Open the bladder. Okay. Like based on the treatment, when you are treating the patient, it can worsen. Maybe there is a different mechanism that is during the pathology, the disease process itself causing that. In case you have, if in case you know about it, just mention it somewhere, please. Hypoxia induced intracranial hemorrhage. How? In RDS. Okay. Vasodilation. Okay. Germinal matrix. Okay, that is susceptible to this one, these changes, and that can lead to this one, hemorrhage. Yeah, makes sense. Yeah, hypercapnia, hypoxia causing vasodilation. Late complication, bronchopulmonary dysplasia due to prolonged oxygen therapy and neurodevelopmental impairments. And then this one we have already seen, and mortality rate is very high, so we need to keep that in mind. Next one, coming to hypoglycemia. Neonatal hypoglycemia refers to blood glucose less than 40 milligram per deciliter, regardless of the gestational age, less than 40 milligrams. It is the most common metabolic disorders in neonates, requiring prompt diagnosis, management, and to prevent neurological sequelae. So definition again, so less than 40 milligrams per deciliter, and this Kornblath operative threshold. Okay, we have certain numbers. Again, first 24 hours, after 24 hours in neonates, that is the first 28 days, neonates with risk factor, neonates with so we have something about neonates with this one, blood glucose very less, they require immediate therapy. Yeah, so let's look at the first one. So 45 milligrams per deciliter, that is the first 24 hours. 30 to 35 milligrams per deciliter may be tolerated but should not persist. After 24 hours, 45 to 50 milligrams per deciliter. Symptomatic neonates, that is less than the 45 to 45 to 50, 45 again, less than 45, it is symptomatic. Asymptomatic neonates with risk factors less than 36. What is this all about? What is it all about? And whether to intervene, when to intervene in neonatal hypoglycemia based on blood sugars. So we have different numbers. So probably I'll copy this. I'll have this thing copied, and I'll use it later on in this one. What is it? I'll replace it with this table. It will come with the lines also. Yeah, over here. This one is slightly confusing. I can't understand what it means. So who is at risk? Okay, fine. Yeah, okay. Something. So threshold action, this is normal. 30 to 35 may be tolerated but shouldn't persist. 30 to 35 shouldn't persist but can be tolerated. It shouldn't persist. Yes, after 24 hours, 45 to 50 normal, no intervention. Symptomatic neonates which is less than 45 or equal to 45 requires immediate treatment. Asymptomatic neonates with risk factors requires, so even after 36 even after 45. Some are asymptomatic, so those guys require intervention. Any neonate less than 20 to 25 requires urgent therapy. Okay, fine. Coming to physiology, glucose stored in the liver as glycogen. Alright, so I'll take a break. I need a break right now. I'll take a break and then I'll see. In case I feel I can do this like another session, something, I'll come back. Otherwise, it will be the end of the video. I'll see how I can do it, but right now I need a break. I'll turn this on and I hear my cough. Yes, I have energized myself and we are going into another session because we want to do more than the last video. Yes, so let's begin. Yeah, where were we? Physiology of glucose regulation. So glucose is stored in the liver as glycogen and released under hormonal regulation. So hormones that are involved, what are those? Glucagon, cortisol, growth hormone, adrenaline. So you need these are insulinogenic. Glucose. You have more of these increase glucose in the blood. Yeah. Neonates also utilize ketone bodies from free fatty acids as an alternative fuel for the brain. Breastfed term babies may have low glucose in first 24 hours, which self corrects. Okay, they may have low blood glucose levels in first 24 hours. So, okay, self correction happens in first 24 hours, which is what we can keep in mind. Coming to etiology, risk factors, and neonatal hypoglycemia. So it can occur due to multiple reasons. So first one is reduced glucose reserve or increased utilization, hyperinsulinism, endocrine disorders, metabolic and genetic disorders. So first one, reduced glucose reserve or increased utilization. So basically the baby is small. So where can that happen? Preterm, small for gestational age, growth restriction, intrauterine growth restriction, perinatal asphyxia, hypoxia, ischemia. This comes up everywhere, but there is no proper mechanism. That is increased utilization. Yes, this could be it. And sepsis, hypothermia. Oh yeah, to maintain the temperature and to clear this thing off, and liver failure and fatty acid oxidation defects. So issues with the liver. All right. Okay, meaning this thing affecting the pathways and the liver and all that. Second section is hyperinsulinism, infants of diabetic mothers. So there are a lot of insulin in mother's body, and it subsequently enters the in the fetus, into the bloodstream of the fetus, and then with that you have this one, Beckwith-Wiedemann syndrome. What is this? Large body size at birth, being taller than average, macroglossia, hypoglycemia. Okay, some arbitrary syndrome. Congenital hyperinsulinism, insulinoma, lots of insulin. So lots of insulin in this particular case, and this is a glucose issue, less reserve or increased utilization. Next is endocrine, pituitary or growth hormone deficiency, pituitary growth hormone deficiency, adrenal insufficiency. So pituitary and adrenals being the main factors. And next come metabolic or genetic disorders, carbohydrate metabolism defects, including glycogen storage disorder, galactosemia, where you can't convert galactose into glucose. Yeah, and then galactose is lost in the urine, is not, yeah, something. Wait, galactosemia, what happens in galactosemia? Galactose in the blood, so rare in that prevents body from properly utilizing sugar galactose. So galactose is used in glucose 1 phosphate, it's converted into that, and then this one is converted into glucose, and you can have energy through this. But if you can't use this, what happens? You don't have enough of this, because primarily this one is coming from the milk. The milk is not being converted into energy, which is primarily galactose, being converted into glucose 1-phosphate, glucose 1-phosphate, right? Glucose 1-phosphate, you have less of energy. Yeah, amino acid metabolism, tyrosinemia. Not going in depth. I think I'll just know the name. Coming to clinical features, 50% may be asymptomatic. Common symptoms in case symptomatic: jitteriness, lethargy, tachycardia, tremors, irritability, sweating, poor feeding. Severe symptoms: apnea, cyanosis, seizures, hypotonia. Jitteriness, lethargy, tachycardia, tremors, irritability, sweating, poor feeding. Okay, fine. Like somehow got to remember this. Apnea, cyanosis, seizures, hypotonia, hypothermia. Investigation and treatment. Investigation: blood sugar, blood glucose. Okay. Electrolyte measurement, cortisol and insulin. Okay, this makes sense because of the etiology, even ketone bodies. So starvation related. How is it connected? In case of liver issues. ACTH and thyroid hormone assay. ACTH is just above cortisol, and like you're looking at the axis, and in thyroid hormone, yeah, thyroid in you can have a lot of glucose with thyroid, but in case there is less of thyroid, hypoglycemia could be suspected. In treatment of neonatal hypoglycemia, asymptomatic neonates determine risk factors. Frequent enteral asymptomatic know the risk factors: frequent enteral feeding, IV glucose if persistent hypoglycemia. So this is from this rate, from here. So based on that, you determine what intervention is required. Symptomatic neonates, immediate therapy, bolus of 10% glucose, 2 ml per kg IV. Maintenance therapy, glucose infusion rate 4 to 10 milligram per kg per minute. Monitor blood glucose every 15 to 30 minutes initially, then every 4 to 6 hours. Okay, some numbers: 2 ml per kg IV, 4 to 10 milligrams per kg per minute. Monitor blood glucose 15 to 30 minutes initially, then every 4 to 6 hours. Refractory hypoglycemia, glucocorticoids, glucagon. Sequelae of hypoglycemia: neurological impairment, cognitive delay, parieto-occipital. Okay, vision impairment in general. So overall, I think this is a good comprehensive understanding discussion. So CDH could be congenital dislocation of hip or congenital diaphragmatic hernia. Yeah, could be both. So it is congenital diaphragmatic hernia in this case, occurs due to herniation of abdominal contents, which could include bowel loops and liver, into the thorax through defect in the diaphragm, leading to mediastinal shift, pulmonary hypoplasia. It is life-threatening condition requiring urgent intervention. Most common, what is this? Bocadelic hernia. I know the name. Knowing the name should be enough, I think. Occurring in posterolateral portion of the diaphragm, posterolateral, behind somewhere. Less common, Morgagni's hernia, hiatal hernia. Let's see the names. In case I can't copy everything at once, it's fine. But anterolateral, one is posterolateral, that is Bochdelic, and Bochdelic. Bochdelic. Then there is hiatal hernia, there is esophageal hiatus involved. Clinical features: respiratory distress because stuff in the abdomen is encroaching the stuff in the thorax, which is supposed to be in the abdomen is coming into the thorax. Characteristic abdominal and thoracic signs. So overall there are some signs and there are chest X-ray findings. So severe respiratory distress since birth or delayed onset within 48 hours. It's honeymoon period. Okay, honeymoon when you are happy, something. Okay. Cyanosis, nasal flaring, grunting, intercostal retractions. Pulmonary hypoplasia leading to acidosis and hypoxia. Yeah, so more of thorax getting encroached by abdominal contents, pulmonary hypoplasia is seen. And characteristic abdominal thoracic signs, scaphoid abdomen due to absence of bowel loops, sunken abdomen, yeah, mid-external shift to the other side, cause a displacement of the heart, yeah, so pushing of the something like this one, what is it, tension pneumothorax, like air enters and everything is pushed to the other side, something similar, but in this case there are abdominal organs which are present in the thorax. Bowel sounds heard in the chest instead of abdomen. Heart sounds displaced to the right in case of left-sided CDH. Chest X-ray findings, bowel loops visible in the thorax. Absent diaphragmatic shadow on affected side. Okay, so we need to see how it looks like. Chest X-ray findings. This is congenital diaphragmatic hernia. Yeah, so look at this, bowel loops, everything is pushed to the other side. Bowel loops in the thorax, absent diaphragmatic shadow on the affected side, venation shift to opposite. Yeah. Treatment, immediate resuscitation, there is definite surgical repair, extra membrane oxygenation, ECMO. So first one, intubation, mechanical ventilation. That could also, you can gastric decompression, correction of acidosis, hypotension, intubation and mechanical ventilation. Avoid bag and mask ventilation as it increases bowel distension. Okay. So bag and mask shouldn't be used. Gastric decompression, nasogastric tube insertion to prevent further bowel distension, correction of acidosis and hypotension. General principles of resuscitation, but in this specific case, don't use bag mask ventilation because it increases bowel distension. Then definitive surgical repair. Timing, after stabilizing pulmonary hypertension management. That is, what's the procedure? Reduction of herniated abdominal contents, closure of diaphragmatic defects, possible prosthetic patch for larger defects. Okay, so surgically correcting the thing. Extracorporeal membrane oxygenation, ECMO, used in severe cases of pulmonary hypertension. So a way of oxygenation using something like similar to dialysis, but in case of respiratory. Yeah, I think it is that. Yeah, it was that. I remember reading about this long back. Prognostic factors associated with pulmonary hypoplasia, worst prognosis, polyhydramnios is bad, lung to head ratio, there is some high mortality risk, neurocognitive delays because of hypoxia and all that, failure to thrive, and GRD. Okay, fine. This one is GRD because the bowel contents, it could be this one also, no? Stomach, the lower esophageal sphincter which is getting affected. Coming to APGAR score. APGAR stands for APGAR, appearance, pulse, grimace, activity, respiration. So appearance, you look at skin color, pulse you look at heart rate, reflex response, that is grimace, tone is, muscle tone is A, and breathing effort is respiration. Developed by Virginia APGAR in 1952 to assess newborn's immediate postnatal condition and response to resuscitation, and it's immediate. And when is it done? First and 5th minute. If by 5 minutes the score is 7, the assessment should be repeated every 5 minutes up to 20 minutes. So at 5th minute mark, if score is less than 7, repeat every 5 minutes till 20 minutes. APGAR score is not used for resuscitation but to monitor response to interventions. APGAR scoring system 0 to 2, 0 point, 1 point, 2 point, 2 points. Heart rate, absent, less than 100, greater than 100. So greater than 100 is good. Respiration, crying is good. Color, pink is good. Tone, being active is good, meaning movements. And reflex response, active withdrawal. but if it is 0, then we'll go to 1. Heart rate is absent, no respiration, blue color, no tone, no reflex. In the middle it is less than 100 heart rate, irregular shallow gasps, pale blue extremities, weak passive tone, facial grimace. Interpretation of APGAR 0 to 3, 4 to 6, 7 to 10. How many? 1 to 3. Here it's 2. Here it's 3. 3 and 2 and 3 points. Severe distress if it is 0 to 3. Moderate distress, monitor and support. In the first case you do resuscitation, last one normal adaptation, good condition. Clinical significance of APGAR scoring. Low 1 minute score suggests perinatal distress, low 5 minute shows higher mortality long term. Neurological defects, percent low score bottom may indicate severe birth asphyxia. So clinically what does the scores mean? That's what it says. So we are done with the newborn chapter. Next, coming to NIS, immunization. So in this particular chapter what I have done, so these two are missing actually, so I didn't add these. So I may add this in the future date, but these two are important. Vaccine, like NIS schedule by itself is very important, and then other than that some vaccines are frequently asked, like BCG is asked, HIV, Haemophilus influenza, that one is asked repeatedly, and the variant. Pentavalent, I didn't see it there in the book, but since HIB is a part of that, I added that also. And there is cold chain repeated multiple times, a lot of times, so that is there. These two are there, but I didn't include them yet. Please make sure that you go through it somehow. NIS updated with 2025 updates. Yeah, NIS is a government recommended vaccination schedule designed to improve immunity against life-threatening infection. In fact, basic introduction. So there are some dosing schedules, protection for infants and pregnant women. Primary objectives: reduce mortality and infant mortality, child mortality from vaccine preventable diseases, enhance immunity in high risk groups, prevent disease outbreaks. So there are three different ones, meaning 3 parts to this. One is for infants, meaning till 1 year, then greater than 1 year, then for pregnant women. So first we'll be looking at for infants what it is. So BCG number 1, most important one, at birth to 1 year, and it could be given up to 1 year. So what is the dose? 0.05 ml up till 1 month, then it is 0.1 ml. Intradermal route, left upper arm. And hepatitis B at birth 24 hours, 0.5 ml. This hepatitis B separately, okay. At birth 24 hours to 24 hours and 0.5 ml, and it's given IM, and it is mid thigh, delayed up to 5 years. And OPV 0, meaning the first dose, oral polio vaccine, at birth to 15 days, and it's oral and 2 drops. So how many drops? Mostly it is any other this thing? No, that's the only thing. Anything else? Yeah, rota is missing from here. Wait a second, let me just check it again. Yeah, rotavirus vaccine, it is given this one, what is it, it's a 6 weeks, that needs to be updated. I'll just update it. What I'll do is I'll add the NI schedule again, but with a different this one, what is it, I'll just make it something like age and vaccines given. This is according to the record. age and when it is vaccine, when it is given, and I will also give the IAP immunization schedule. Depends on, like, NIS is the most frequently asked, frequently meaning it is the most important one. IAP can go through. Yeah, so mainly, yeah, so I'll go through this right now. So at birth you'll be seeing this when you are what is it, right now it is looking like this, but when you are on the website, this will be different compared to what it is now. So at birth, BCG, oral polio vaccine, and hepatitis B birth dose. So hepatitis B birth dose, or else better to keep this here. I'll keep this here, this one, like this is like proper detailed information of what is there. But then in addition to this, better to write it in a different format so that it's easier to grasp. So you need to look at, if you look at both the tables, this table that I have in front of me, this one, and also this table, you would be able to grasp it more easily. That's what I think. You are free to choose the best way. Maybe you already know the entire analysis and you can skip this part of the video. Coming to at birth, there is BCG, oral polio vaccine 0 dose, and hepatitis B birth dose. So these three are the at birth, even at birth, and BCG is intradermal, hepatitis B intramuscular, and OPV is oral, and this one is left upper arm up to 1 year, mid thigh, and this one is oral, delay limit up to 1 year, and these two are for 5 years. So at birth we are done, whatever you give, we need to give at birth. Next, coming to 6 weeks. So 6 weeks, some vaccines are given at 6 weeks. So what are those? One is OPV 1, which is bivalent OPV. This 1, 2, 3, but it's like 1 is the most common. One is the most common one, and no, it's, wait a second, I said some. I'll call it OPV. Okay, OPV. It is sorry, OPV 1, 2, and 3, meaning OPV first dose. I got confused. Sorry. OPV first dose, OPV second dose, OPV third dose. It's 6, 10, and 14. IPV are 2 doses, 6 and 14. And OPV is like 2 drops. It's oral, just like the previous one, and it can be given anytime. So that part, OPV part, we are done. Now IPV, it is just 6 and 14, and it is intradermal right deltoid. Intradermal right deltoid. First one was left upper arm. This is right upper arm. 0.1 ml. Then there is pentavalent. Pentavalent, it is 6, 10, and 14. Similar to the 6, 10, 14. That one, both are same. No, I'll add this one also. Sorry for the confusion. I'll get some recommendations and see which one is the best thing to add, or else I'll add from the government website itself. I'll just bring it and put it here. So it is directly from the government 2025 update. It would be very easy to, it would be the updated latest one. Very nice. Yeah. This one, pentavalent, is 6, 10, 14. Similar to this and similar to this, 6, 10, 14. And it's 0.5 ml. It is IM. Similar to hepatitis B is here. Hepatitis B is here. So it is mid thigh, and up to 7 years. There it was given separately, okay. This one separately, these two. But here it is combined with DPT and HIP. First, second, third dose. That is 0th dose at birth. But the route is same for Penta and Hep B. Next, coming to measles. Measles is 9th month. Measles, and there is Japanese encephalitis, which also comes with measles. With measles and rubella, actually, MR. It's measles and rubella here. And then measles first is here. So measles is 9th month, and there is JE also, Japanese encephalitis over here, and measles it is subcutaneous MR, and right upper arm it could be given up to 5 years, and this is given along with this, the first dose given along with the measles, 1 ml oral and up to 5 years. Now in this till 1 year we have finished 6, 10, 14. So this was 9th month, the last NIS, the last for the this thing for the infants. Next, coming to children. So we continue some of the vaccines from here and continue it here. So pentavalent booster. So pentavalent, and there was another one. There are two actually which are missed here in this particular case. There is PCV and there is PCV and rota. Those need to be added, pneumococcal and rota. So I will make sure to add it, update it here, so that it's easier to. So that's the thing. Different textbooks and all that, it gets confusing. So I'll update it after this section. NIS. I doubt the only things that I feel are the issue that could be an issue over here in this particular website are the things that are like constantly updated, and some books have it in different way, some books have it the other. So in that particular case, better to go for the latest information from the latest updated books. So PCV and rota, those two need to be added here. And then so where were we? 16 to 24 months. 16 to 24 months, lot of things happen. One is pentavalent booster. Pentavalent is given. Then MR is given, not MMR, it's MR. MR is given. JE, which I told you over here, it's also given. That is the second dose of JE, Japanese encephalitis. And then DPT booster is also given here, one of them. The first DPT booster is given here in this particular section, meaning DPT is included in that in this particular thing. Sorry about that. So pentavalent contains DPT, this one I'll just mention it properly. So pentavalent contains all these three things, and the booster of all these is given in 16 to 24, which is exactly the same thing as this, which is similar to this one. What is it? The hepatitis B. So the thing is, it would be best in case you skip this particular section, but in case you want to listen, you can listen and go through the NIS. So things like the developmental milestones, the NIS schedule, all those things require proper focus and nice creative energy from your side to remember. Like I can't do it, I can just speak and it might not be a lot more it won't be helpful to you, but in case you just go through it yourself, it would be much better. And this is a long form thing, so say even I am tired right now. Like I shouldn't be saying this in the video, but it's fine. Vitamin A, then there is, so these three we have finished. So 16 to 24, and OPV booster, this one we didn't do. OPV booster, so this is also given during 16 to 24 months. So 16 to 24 months, three important things: pentavalent booster, OPV booster, MR booster, and along with MR, what else did we have? JE booster. So another one, fourth, that is the fourth thing. Yes, and so JE vaccine specifically, better to put it here. I'll update it. It is important actually. So that one, what else? Then there is 16 to 24 months done. Okay, that one is over. Now there is vitamin A, 2 to 9 doses. So vitamin A, is it given along with the measles? Yeah, it is given along with the measles, but next 2 to 9 months, 2 to second to 9th dose. Now it is this is the different one actually. The first dose is given here of vitamin A here in this. This is the first dose of vitamin A. Another dose of vitamin A comes here, and it goes on and on for 5 years, and it's given every 6 months, 2 ml. The same thing, oral route. And then there is another DPT booster. This is something different. So this DPT booster is 5 to 6 years, like one of the last ones, DPT booster. It's not Penta, okay. Penta is here, it stays here, it stays there, and the rest of the things like hepatitis B, they end here. But DPT continues, and it is here with 5 to 6 years, 0.5 ml as the dose. IM is route, IM is the route, and upper arm. Yeah, so then DPT booster has changed its position from mid thigh to upper arm, and there is tetanus toxoid TT 10 years and 16 years, that is the last one. This 0.5 ml IM, and it is upper arm. So this could be jumbled in, it could be like everything is upside down, everything is everywhere. So I suggest you to go through this again after right now, or after pausing this video, or like later on after this particular session, but better to go through it in detail properly again. We have additionally spoken about, in addition to all these, we have spoken about MR, we have spoken about Japanese encephalitis. Do you understand? MR, Japanese encephalitis. Yeah, so next, immunization in pregnant women. There is TT1, which is given in early pregnancy, TT2, which is given 4 weeks after TT1. Both are IM route, 0.5 ml, and upper arm. All are upper arm. And in case booster is given, it is if received 2 TT doses in pregnancy within last 3 years. That is 0.5 ml IM upper arm. So what are the key updates? IPV is included at 6 and 14 weeks, measles too. So actually it's MR, measles and rubella. Vitamin A supplementation up to 5 years. Pentavalent replaces old DPT. So but one of the DPTs, as I mentioned, DPT booster is still there, 5 to 6 years, and it has changed its route from mid thigh. Comparing it to pentavalent, it is upper arm. That is one thing. And what else? Expanded immunization for BCG to include up to 1 year, hepatitis B and measles up to 5 years. And special considerations, GE, this one and Rota. I'll add these here to make sure that it is complete. I'll make it more comprehensive, meaning proper, so that you can understand properly. Then there is SPV and MR. Yeah, so this one NIS is mostly covered. I'll add additional things, but with the I feel my understanding has improved, meaning I knew the NIS, but the more explain it, the better it is for me. BCG vaccine, it's a live attenuated vaccine derived from Mycobacterium bovis, used to provide immunity against TB. Most widely used vaccines, particularly in endemic regions. Strains: Copenhagen, Pasteur strain. It induces CMI, essential for potential Mycobacterium tuberculosis. Schedule: given at birth, that is 72 hours, within 72 hours. Wait, that is nice. Yeah, it's not mentioned. Within 72 hours, it should be given within 72 hours. MS can be administered up to 1 year. Catch up is allowed until 1 year. Storage 2 to 8 degrees. This number is going to be repeated so many times. Diluent is normal saline, must be discarded within 4 hours. This is something, these are the properties. Properties meaning of how it should be stored, and I can't just memorization. Highly sensitive to heat. Maybe these are very commonly these I have seen that these particular points repeat themselves in multiple vaccines. Dosage we have seen earlier, 0.1 ml, and in case like early, like at birth or something, it's 0.05, and intradermal injection and the site is left deltoid, left upper arm. Clean the site, avoid antiseptic. Expected events: wheal formation, papule increase in size, ulceration, scar formation. So there is wheal, red swelling, that is the papule, and gradual increase in size of papule, ulceration. So everybody has that BCG scar, like whoever has received the vaccination. Immediately after vaccination, so this numbers 2 to 3 immediately is wheal, 2 to 3 weeks is papule, 5 to 6 is with increase in papule, and then 6 to 12 is ulceration. Efficacy: 80% protection against miliary TB, 50% against pulmonary TB, no protection against leprosy or other disease. Adverse reactions: local reaction, so this is expected. BCG abscess, surgical removal may be required. Lymphadenopathy: ipsilateral, axillary and cervical lymph nodes enlargement. Severe complications: disseminated BCG infection. So lymphadenopathy is like similar to actual TB infection where lymph node enlargement is seen, but in this particular case only if you find systemic infection you give anti-tubercular treatment. And then severe disseminated occurs in case of severe immunodeficiency and osteitis. Special consideration: BCG can be in HIV positive infants unless the baby has symptomatic AIDS. It is contraindicated in, like it is given in everyone except congenital immunodeficiency syndrome, children on immunosuppressant drugs, dermatological infection at the infection site. BCG is given with all vaccines except MMR measles. A 4-week interval is required. MMR, that is the only thing. MR. So that one is done. This one is done. Haemophilus influenzae. This one I have written it as if it's a 5 marker. So Haemophilus vaccine is conjugate vaccine designed to protect against severe infections. And what does it cause? Meningitis, pneumonia, epiglottitis, septic arthritis. It is used to prevent life-threatening infections. Vaccine composition and types. So Hib vaccine, so conjugate vaccines, and there is type B polysaccharide, which is linked to carrier protein to enhance the immune response. So I wouldn't learn all of this, it's like too technical. Conjugation improves the immune response, especially in less than 2 years who do not mount an adequate response to polysaccharide. So the conjugation is required for better immune response. That's what the key takeaway is. Disease is prevented. So what does Hib cause? And those things are prevented. So meningitis, bacteremia, pneumonia, epiglottitis, septic arthritis, otitis media, sinusitis. So this number is same thing. Do not freeze or do not this thing. Shake well before use, ensuring proper system. So it is not light sensitive. That doesn't destroy it. Dosage: IM 0.5 ml. So this one, I think the old that one we can write. What is the from the NIS along with Penta. This one, booster dose 12 to 18 months. This is additional. Can give this for better long-term immunity. Side effects, so site related, pain, redness, swelling, low grade fever, allergic reactions. Contraindications, severe allergic reaction to previous dose, severe immunodeficiency, current severe illness. Vaccination should be delayed until recovery. So in this particular case, if the child already has some kind of infection, hip infection, it should be not hip infection, any kind of illness, severe illness, don't give it. Yeah, so this one is hip is done. Pentavalent, actually this one is not a Singi question. I haven't seen this in Singi. I just added it because Haemophilus influenza is a part of this, but I'm not sure if I should be discussing this because like most of the things, like these are things that repeat. Most of the things repeat themselves. This is the same thing, anterolateral thigh. And what are the components? So what do each of the organisms cause? That should form the introduction part of the answer. That is what I feel. Yeah, so I wouldn't be discussing this because this one mostly is this itself and whatever I discuss here. So site and all that, and this one you can go through. This one I'll add it, and also these two are very important. But overall 9th, where have we reached? 9th. Where did we cover? 1, 2, 3, 4. So by the end of this, within 8 minutes, we can cover immunization. We can finish this section. The infestation may be probably in the next video. Yeah, we'll just finish it off. We can go to the next section actually. We can start with infestation and see where we reach within the 8-minute mark. Definition is a system of storing, transporting vaccines recommended at low temperatures from the site of manufacture to the vaccination site, ensuring vaccine potency is maintained until the administration. So what are the different stages? Manufacturer, distributor, vaccine depot, provider site, consumer. So what are the equipments? This is I think a 3-marker. This is a 3-marker. Walk-in rooms, deep freezers, ice-lined refrigerators, cold boxes. So these two are the refrigerators. There are 2 refrigerators, and there are big rooms which are very cold. There are cold boxes. These are carrier like you use them for the transport purposes. And this for ice packs is placed inside the vaccine carriers. So regional level storage for 3 months, reserved for 4 to 5 districts. So these are big cold rooms. Should I show an image? Yeah, I think better. There's time, right? Walk in cold room. Yeah, this looks like something from Money Heist, where you store the gold and all that. Yeah, second, deep freezers, minus 15 to 25, used in large districts and PHCs, maintains temperature even during power failure. Interesting. Ice-lined refrigerator used at districts PHC level for hepatitis B, DPT, BCG, OPV, the basic vaccines. Ice-lined refrigerators. Cold boxes used in peripheral centers. So from here, the peripheral center that keeps repeating. So from here, this is the mark. So become urban to rural. So even this one can be at a rural level, PHC, right? And this one, it depends. Ice packs placed at the bottom of the side. Vaccine carriers, portable storage of outreach programs, hold 16 to 20 vials. Uses 4 It's 9th March. Vaccine field, ice packs, no salt, discarded if so the vaccine carriers include the vials themselves and the ice packs, but overall this is a 3 marker, so this one should be enough. That's what I think. And we will start with the next one. Enteric fever, also known as typhoid. So typhoid, it is an acute febrile illness characterized by prolonged fever, hepatosplenomegaly, lymphadenopathy. 3 things: prolonged fever, hepatosplenomegaly, lymphadenopathy. It's caused by Salmonella typhi, Salmonella enterica, serotype typhi B, serotype typhi. And there is also Salmonella enterica, serotype paratyphi. So there is, there are 2 variants of enteric fever. One is typhoid, and one is paratyphoid. Typhoid caused by this one, what is it, Salmonella typhi, and paratyphoid caused by Salmonella paratyphi. There are 3 different variants, A, B, C. Fecal-oral route, and sources of infection direct, like primary, secondary, directly from the infected carrier, that is primary. Who was that? Some typhoid Mary, that was the one. Secondary, contaminated water, and is the mic on? Mic is on. Secondary, contaminated water, food, fingers and flies. Etiopathogenesis. So causative organism, typhi and paratyphi. Gram negative non-lactose fermenting flagellated bacteria. Let's see an image of Salmonella typhi. Salmonella typhi. See, some motile. That's flagella. Non-lactose fermenting. Key antigens. So this one, as you can recall, it's used in Vidal, O antigen, H antigen and all that. So that those are 2 things, somatic O antigen and flagella H antigen, and capsular V polysaccharide V antigen, and this is virulence factor, and infected 10 raised to 3 to 10 raised to 6. I'm not sure if you need to remember, but it's mainly for comparison purposes, like Shigella has very low infective dose and all that. So I think that is the only till now, that is the only thing that I've seen, like in terms of infective dose, Shigella being the requiring least infective dose. Incubation period, children 8 days, adults 10 to 14 days. What is the pathophysiology? Ingestion of contaminated food and food or water reaches Peyer's patches in the ileum, perforate and gain access to lymphatics and bloodstream. This one, there is one section on this, like what typhoid ulcers in surgery. Which one is surgery GI tract, which is surgery, in the ulcer section. I'm not sure whether it's the GI paper one. There is ulcers, right? That one, that could be one, or there could be GI section, that is in paper to abdomen. I think it's in the GI section. So there is a detailed about these ulcers. Primary bacteremia, organisms spread to reticular endothelial system, which is liver, spleen and bone. This is primary bacteremia. So the primary and secondary, what is that? Cause sources, and here there is primary and secondary bacteremia. Primary bacteremia we have seen, reticular endothelial system. Secondary, organisms re-enter bloodstream causing fever and systemic symptoms. So they go there, then they come back. Then gallbladder involvement, infected bile is excreted into stools, leading to fecal-oral transmission. So gallbladder is the main one. Clinical features. So 1, 2, 3, 4. So 4 weeks. First week, fever is you have fever, malaise, headache, non-specific symptoms, sore throat, nausea, abdominal pain, pea soup diarrhea. That's the first week. Hepatosplenomegaly. Second week, gaseous abdominal distension, diarrhea is still there, rose spots, pink maculopapular rash on chest and abdomen. Third week, the proper typhoid state, where there is toxemia, apathy, delirium, encephalopathy, intestinal perforation and hemorrhage. So it's like brain is affected, intestines are affected, blood. Next there is blood, meaning blood from the perforation. 4th week, gradual recovery if there is no complication. Important signs: relative bradycardia, fever with, oh, I never knew there was a feature like this, long break. It's fine, it's a good thing. But anyways, what do I think? Should I take a break? What time is it? 3 hours 55 minutes. We are done with 4 Pomodoro sessions. I think 4 is enough for now. Maybe later on, I think I'll see. I think I'll make another. I'll start with another one later in the night. I'm not particularly sure, but I need a break. So I'll stop this at this point of time, and let's see where we have reached. So we have finished the half the clinical features, the main important one based on the weeks. So after this we'll be continuing this, and that next particular section we should have covered the entire infestation. This should be done by today, hopefully. Then GI and liver, how much is it? This one entirely we can cover it today if we try. GI and liver, I'm not sure, because the thing is, half of it is like, most of it is like in medicine. Now most of the things will be like medicine related. Most of these medicine. This one is a small part, but it's like it's a smooth flow. So let's see. I don't actually know what the pacing is, how fast we are going to finish all of this. I haven't planned this. Even when I'm explaining things, the thing is, it is what is this? Encoding overloaded. Consider turning down video settings. Hopefully the video is working properly. Like, I'll stop this and I'll see how the video is. Hopefully it is good. Like, even then, I think, yeah, the thing has disappeared. Yeah. So where was I? Yeah. So I actually haven't planned how to go about doing. I'm just going on and on, just studying, and on the camera. So that is the idea behind this. Like, how I'm using the site to study, and how can you do it too, along with Google and our ChatGPT. So personally, I feel these are really good resources for last minute preparation, or in general. Like, for example, you're out somewhere, you can't carry the books or something. This is such a good thing. Only like books make sense in case you're sitting in the library and you have access to books here right now. But in case you are already using iPad and all that, you can like, this is a really good resource in my personal opinion. You're free to disagree. Yeah. So 3 minutes, almost 3 minutes for 4-hour mark. I'll just stop this at this point. So I'll be probably another video in next few hours. We'll see how it goes. Anyways, in case you like this particular study session, a big one, you can like this video. In case you would like to contribute anything, meaning any suggestions, any criticisms, any mistakes in the notes or something, you can just write it down or DM in the Instagram. And yeah, so that's it. In case you have any ideas, you can share it. Okay, and bye bye.